Good day, ladies and gentlemen, and welcome to this group meeting that is focusing on the management of metastatic colorectal cancer in honor of Colorectal Cancer Awareness Month. I'm Filomena Servideo Italiano, the very proud president and CEO of the Colorectal Cancer Resource and Action Network. We are hosting 4 remarkable experts today who will be sharing information on the management of metastatic colorectal cancer. So I do understand that we have a few members who have joined us today who are not necessarily familiar with the Colorectal Cancer Resource and Action Network, or more affectionately known as CAN. So I'm just going to go through a few slides with you so that you can become better acquainted with us. We champion the health and the well-being of Canadians touched by colorectal cancer, as well as others who are at risk of developing the disease. Our goal is to identify and address the unmet needs of both the metastatic and the non-metastatic patient population to try to improve the longevity and the quality of life for patients. We aim to deliver our services with compassion and care at all times, because most of us at CRAN have been through the journey, such as myself as a caregiver or as a patient. We recognize that the journey is fraught with so many challenges and isolation and loneliness, which is why we are so passionate about what we do. Our mandate at CRAN is to deliver a sea of services: support, education, and advocacy. And when it comes to support, not only do we deliver psychosocial support, but we deliver our support services in the form of evidence-based information to help improve that longevity and patient outcomes in the form of quality of life and survival. One thing that we have done at CRAN recently is we have expanded our mandate to now be supporting patients outside of the colorectal cancer space by providing HTA patient evidence submissions. We are preparing these patient evidence submissions for oncology drugs outside of the colorectal cancer space for patient groups who may not necessarily have the capacity to perform these submissions, or within a therapeutic area where there may not necessarily be a representative patient group. We believe that it can indirectly benefit our colorectal cancer patient population by seeing to it that there are multiple indications or funding approvals. And it can certainly impact the lives of multiple tumor type patients in Canada. Just in the past, let's say 6 to 12 months, we've participated in this process. And we've seen to it that we've made a submission for bile duct cancer, cholangiocarcinoma, endometrial cancer, cervical cancer, all of which have resulted in positive funding recommendations. And I've just recently made another submission for hepatocellular carcinoma or liver cancer. And our hope is that a positive funding recommendation will ensue. So we'd like to get started. Just a few friendly reminders, my friends. Kindly mute your screen. All experts will be accepting questions from you at the end of their respective presentations. You can ask your question either at the end of the presentation, or you can submit via the chat function at the bottom of your screen. Today's patient education session is absolutely being recorded, and we will be forwarding it along via a link that will be sent out via social media as well as through an email blast. And we are always looking to improve our patient education sessions. So we're going to be sending you a session evaluation form for your kind feedback. Here's the agenda for today's session. Dr. Ron Burkes will be speaking first. Dr. Marcelo Cypel is second, who's a thoracic surgical oncologist. Felicia Newell, our registered dietitian, will be up next, and we'll be concluding with Ms. Nicole McCormick, who'll be speaking to the introduction of ctDNA in Canada. On that note, I would like to introduce Dr. Ron Burkes, who is our first speaker. Dr. Ron Burkes is a professor of medicine at the University of Toronto and staff medical oncologist at Mount Sinai Hospital, Princess Margaret Cancer Centre, University Health Network in Toronto. He was on the Medical Oncology Training Committee for the University of Toronto for 23 years and the Program Director for the Medical Oncology Training Program from 1996 to 2005, during which time he introduced the academic half-day, the longitudinal clinic experience, the annual Medical Oncology Research Day, and the Staff Medical Oncology Outstanding Teaching Awards. He was also the director of the Clinical Teaching Unit at the Princess Margaret Cancer Centre from 1999 to 2005 and established the teaching curriculum for the internal medicine residents rotating through the PMCC, or Princess Margaret Cancer Centre. He is now the Medical Oncology Mentorship Facilitator for the Division of Medical Oncology, Department of Medicine, University of Toronto. He has won numerous teaching awards, including departmental and university-wide awards on 18 occasions, the Anderson Award in Program Development and the Hasselbeck Teaching Award at Princess Margaret Cancer Centre. He has presented at many local, provincial, national, and international meetings. His research interests include lung and GI malignancies, with a primary interest in lung, colorectal, and gastric cancers. He has numerous publications, including 128 peer-reviewed, 154 non-peer-reviewed, and 2 book chapters. And I'm very honored to say that he is a valued member of CRAN's Medical and Scientific Advisory Board. I am very pleased to introduce to you today's first expert speaker, who will be delivering content on the medical management of metastatic colorectal cancer. Ladies and gentlemen, Dr. Ron Burkes.
Well, thank you for that very kind introduction, Philomena. Let me just share my screen. Anyways, it's a pleasure to be here, and thank you all on a Sunday for participating in this CRAN event and patient education in honor of Colorectal Cancer Awareness Month. I'm going to talk to you about medical management of metastatic colorectal cancer. Next slide. These are my disclosures. Next slide. So the objectives for today, what I've been asked to talk to you about, is to review the drug therapies we use to manage patients with metastatic colorectal cancer, to differentiate between MSI high and MS stable disease, to review the concept of precision medicine and the use of biomarkers in guiding our treatment decisions, and then finally touch upon the potential use of ctDNA in managing colorectal cancer. I know there's a talk a little later on about this. So I'll sort of segue into that with some comments at the end. Next slide. So we've certainly come a long way. Next slide. And I started practicing in 1985. And at that time, we had, these are the drugs we had available to us. We had 5-FU, next slide, 5-FU, and again, 5-FU, once again, 5-FU, another one more. And then finally, we started playing around with trying to modulate 5-FU, or 5-fluorouracil. And there were a number of studies looking at different drugs that we would add to 5-FU. Here it's methotrexate. Another one was with interferon. All these did was increase the side effect profile without really much benefit in terms of increasing the activity of 5-FU. Next slide. And the winner in the end, as most of you know, if you're either a patient or caregiver, is leucovorin added to 5-FU. And the other thing we learned over the years, the Europeans learned this long before the North Americans, and the US was way behind even Canada, is that infusional therapy, or giving 5-FU over 46 hours, is better than giving it as a bolus, which is a shot over 20 minutes or 30 minutes, which is the way we used to do it. Next slide. So we are now in an era of plenty, as you can see here. In addition to 5-FU, We have capecitabine or Xeloda, which is the oral form of 5-FU. We have irinotecan. We have oxaliplatin. We have the monoclonal antibodies, bevacizumab, cetuximab, panitumumab. We have newer agents, regorafenib and Lonsurf. And now we have the BRAF inhibitor, encorafenib, and one of the checkpoint inhibitors called pembrolizumab. Next slide. So clearly we use combined therapy, combinations of drugs, and these are the options that we have available to us at the present time. We have FOLFIRI, which is irinotecan-based therapy. We have FOLFOX, which is oxaliplatin-based therapy. We have Zelox or Capox, which is the giving capecitabine with oxaliplatin. Sometimes we give everything at once, FOLFOXIRI, and then we sometimes add a biologic such as bevacizumab or cetuximab or panitumumab for patients who are MSI high or MMR deficient, and we'll discuss this in a bit. We use pembrolizumab up front. In the second line setting, if somebody has a BRAF mutation, we use encorafenib with cetuximab. And then we've had Lonsurf available for a number of years in the third line setting. And the Sunlight trial just presented in the GI ASCO meeting in San Francisco a few months ago has shown clearly that adding bevacizumab to Lonsurf significantly improves the outcome over Lonsurf alone. Next slide. So we're now in an era of what we would call precision medicine, or better known as personalized medicine, which is an innovative approach to trying to tailor disease prevention and treatment, taking into account differences in people's genes, environment, and lifestyles. It's also very valuable in terms of drug development because we can employ biomarkers to stratify patients in clinical trials with the goal that we are directing a new drug directly against a particular biomarker to improve efficacy, safety, and ultimately the odds of having a positive clinical trial to get drug approval. Probably the classic example of this is patients with lung cancer who have a specific mutation that we call ALK. When the first drug against ALK was developed, called crizotinib, many years ago, the results of that study in previously heavily treated patients was phenomenal. If that drug was developed even 5 years earlier than that, and we treated every patient with lung cancer, guaranteed crizotinib would have ended up in the garbage. But because you were only giving it to patients with that particular biomarker, the results were phenomenal to the point where it was one of the first drugs, I think it was the first drug that the FDA approved based solely on very early trials. Next slide. So here's a pie diagram of all of the various mutations that we know of, at least today, in colorectal cancer. Some of these are actionable, some of them are not. About 45% of people will have what we call a RAS mutation. About 26 will be RAS wild type so that we can give anti-EGFR therapy. BRAF mutation seen here in green is in about 8% of patients. And specifically with BRAF, it's BRAF V600E. So there's a number of different BRAF mutations. The one in particular that we target is the V600E. We have MSI in about 4 or 5% of people, and there's a whole host of others that clearly we will be hopefully be able to target in the not too distant future. Next slide. So here's a diagram of sort of all of the different biomarkers that we have with the drugs that we have available to us. So the VEGF agents, such as bevacizumab, that's the ones that are approved. These are in bold. There's a whole host of others that some we don't have available to us. Some are undergoing investigation. We have drugs that target the EGFR receptor, such as cetuximab and panitumumab, the BRAF inhibitors, and now also HER2. We'll talk about that in a minute as well. And then finally, the immune checkpoint inhibitors, specifically right now, we have pembrolizumab. And I put a star to the bottom right corner here just to remind me, because I think that many patients that I see really don't understand the disconnect between Health Canada approval and funding. So just because Health Canada approves a drug doesn't mean that the drug is going to be funded. that has to go through a lot more bureaucratic things before that ultimately can happen. That's a whole talk unto of itself. Next slide. So here's the key biomarkers that help us today inform treatment in metastatic colorectal cancer. Now, I'm not talking about patients who are potentially resectable, patients who may have metastases to the liver, for example, that we are hoping to get to surgery. That's a whole different talk by itself. So right now, the key biomarkers are RAS, so it's KRAS and NRAS. We just call that all RAS, BRAF, and then, of course, MMR or MSI status. The other thing that's important is, next slide. The other thing that's important is to know the difference between the right side and the left side. We've known for a number of years that there is, in fact, a difference between the right tumors arising from the right side of the colon and the left side of the colon. So, for example, right-sided tumors tend to occur in older people, more often in females. They often present later because the bleeding is very occult as opposed to clear bleeding from the left side or lower bowel. Often the polyps that are seen are sessile or flat, and so it may not be seen easily with colonoscopy. Tumors tend to be of high degree of differentiation under the microscope. They can be often signet cell and mucinous tumors under the microscope. And commonly, we see what we call peritoneal metastases, which is spread of the tumor to the lining of the abdominal cavity. Next slide. Now, why is there this difference between the left side and the right side? And we're not really sure, but what we did learn a number of years ago now is that the use of these EGFR inhibitors, panitumumab or cetuximab, also is different. The benefit is different on the right than the left. People do much better with left-sided tumors getting these drugs if they're RAS wild type than the right side. So we're not sure why. We do know that the embryologic development of the colon, it comes from two different parts of the embryo. The right-sided tumors come from what we call the midgut, and the left-sided tumors come from the hindgut. The other area that's really being actively investigated today is the gut microbiome or the gut bacteria. And we know that this is a hot area of research. We know it may be important in immune or immunotherapy development and management. And we know that there's a host of changes that occur from the right side as we go through the transverse to then the descending colon on the left side, and that the gut bacteria changes. And so these may all be some of the reasons why we see these differences between left and right. Next slide. And then just next slide a few times, just keep pressing it. I'll tell you when to stop. Next, 2 more times. Perfect, thank you. So no, one more, go back. Great. So these are the American Society of Clinical Oncology, this ASCO guidelines. It's a society we all belong to in terms of where we make decisions in terms of treatment, where there's a fork in the road, yes or no. I'm not going to this into any detail. It's very complicated. Next slide. But what I've done on the next slide is just summarize the key things that we consider before we start treatment. MSI status is important. The RAS, the BRAF, and as I mentioned earlier, left versus right-sided tumors. Next slide. So in 2023, we really have a biomarker-driven approach to the management of patients with metastatic disease. Again, I'm not going to go into any of this detail, but I think what this shows you is that it's not so simple. When you see your oncologist for the first time, it's not always so simple just to say, this is what we're going to do. We need a lot more information. Sometimes that information is available to us when we see you. Sometimes it is not available. More often than not, unfortunately, it's not available. I'll come to that in a little bit. But there's a lot of different, if this is the route we go. If it's this is the route we go, both in first line, second, and third line options. Next slide. There are a number of biomarkers that are starting to emerge in addition to what I've just talked about. The two that I think are probably most important right now are HER2, which is, some of you may know from breast cancer or stomach cancer, the HER2 mutation, and something called NTRK. And both of these actually are actionable. And these are sort of emerging biomarkers in addition to what I've already talked about. Next slide. So this is just a cartoon of the various parts of HER2, the receptor or mutation that can be targeted. Again, I'm not going to go into detail. It was just mostly to show you that even with HER2, it can be complicated, but there are many different parts of the HER2 mutation that can be targeted by different drugs. Next slide. And one of those that's being actively developed in a number of tumor sites, including lung cancer and breast cancer, and also now in colorectal cancer, is something called T-DXd. So T-DXd is what we call as a antibody drug conjugate, meaning it's composed of three different components. One of the components is actually an antibody directed against HER2. Other components are the payload. They help deliver this antibody better to the drug. So these are now being developed. There have been lots of studies now recently that show that these are very promising in lung cancer and more recently in gastric cancer. And just to give a shout out that we will be starting a clinical trial called the Mountaineer study any week now, hopefully any day, but more likely in the next couple of weeks. We'll be starting a study at Mount Sinai for patients who have never been treated before, who have a HER2 mutation, looking at these drug conjugates. So this is actively being investigated, and we'll see. We're looking very forward to hopefully successful clinical trials. Next slide. The other newer one is something called tropomyosin receptor kinase, or TRK. This is a fusion gene that is seen across multiple different cancer types, both in adults as well as children, and it's seen in colorectal cancer as well. Interestingly enough, these TRK fusions tend to be more common in rare tumors and less common in the common tumors, such as colon and lung. Next slide. So in colon cancer, they're only seen in just under 1% of patients, so very uncommon. The good news is that, two good news. Number one is that the chances of having an NTRK fusion gene is that it is more commonly seen in people with MSI high disease, RAS and BRAF wild type disease, and something called an MLH1 promoter gene. And in those people, it can be up to 30% of people. As of April 1st, the good news here in Ontario is that Cancer Care Ontario is finally going to have funding to make this test available. Next slide. And the importance is that we have a drug that can target people with NTRK. So I'm just going to show you this slide. I'll explain it a little bit. This is what we call a waterfall plot. And what this basically means is when we do clinical trials, we measure the response to treatment with something called RECIST. And anything that has a shrinkage of greater than 30% is called a response. But we also know that there are many people who don't seem to have much shrinkage of their tumor, but they feel significantly better. And that's because there are people whose tumor shrinks, but if it doesn't reach that 30% bar, it's not considered a response. And if you look at anything below the zero means there's been benefit. And each of these bars is a single patient on the study. And what you can see here is that almost everybody benefited if you had an NTRK fusion and received this drug called larotrectinib. Very few people, anything above the zero mark going upwards means it didn't work. So almost nobody had progression of their disease, and almost everybody had shrinkage, some a complete disappearance. So when you get down to the 100 mark at the bottom, that means zero cancer left behind, at least in terms of what you can see on a scan. Next slide. So the key message I'm trying to get across here is that testing of key clinical biomarkers can help drive the selection of targeted therapy in patients with metastatic colorectal cancer. Next slide. And this is the current standard of care. We do something called, the pathologists do, immunohistochemistry testing for the 4 key genes for MSI. This is MLH1, MSH2 and 6, and PMS2. We do genetic testing for some of the other mutations, including MSI can be detected, BRAF and KRAS, and these help direct which drugs we would add to the treatment. We can use the primary tumor to test. We can use biopsies of areas that have spread. And now we can also look in the peripheral blood for circulating tumor DNA. We'll come to that a little later on. And we can test for these mutations as well as multiple other mutations as well. Next slide. So this is just some of the potential benefits and applications of liquid biopsies, we call, as opposed to tissue biopsy, a liquid biopsy, which is just a blood test. And we use next generation sequencing to look for a whole host of mutations. Some of the potential applications, clearly it's minimally invasive. It's a blood test. It can be done a lot quicker because we don't have to book a biopsy time, which can often take a number of weeks, as I'm sure many of you have experienced. And it can be repeatable so that we may detect other mutations that develop that cause resistance to the treatment that we are presently using, and hopefully develop new drugs that then target the resistant mutation. And we can then do serial testing much more easily. Certainly this application is far advanced in lung cancer, where we will test repeatedly when people are starting to progress, looking for any newer mutations that we might be able to target. Current limitations, of course, are cost is a big one. This does not come cheaply. And secondly, there are a number of different platforms for doing these tests. And so there are issues with validation and accuracy and reproducibility. So in summary, basically, there still is insufficient data to support routine screening of colorectal cancer patients with these NGS panels that extend beyond the genes that we can now target. And that's the key, is that at the moment, other than clinical trials, we can't target many more than what I've already talked to you about today. Next slide. So key messages. The current standard of care that biomarkers include extended RAS, BRAF, MSI or microsatellite instability, HER2, and then NTRK as of April 1st. And primary tumor location needs to be taken into consideration as well. For me, reflexive testing we define as not the oncologist asking for these tests to be done, but the pathologist who sees the tumor before we do, doing these tests automatically when they see a colorectal cancer patient or tissue. And this is key in testing at least the basic tests so that we can choose the best treatment for our patients. Next slide. At the moment, this is what Cancer Care Ontario recommends for treatment in the first-line setting. If it's a RAS wild-type tumor on the left side, we give chemo, either FOLFOX or FOLFIRI, with either cetuximab or panitumumab. The paradigm study that was just reported last spring in the oncology meetings from Japan has proven beyond a doubt that there is a difference with EGFR monoclonal antibodies between left and right. So for right-sided tumors that are even RAS wild type, they should be treated with the same chemo, but with Avastin and not an EGFR monoclonal, again, assuming there's no contraindications to giving bevacizumab. In the second-line setting, patients who were treated with an EGFR monoclonal instead of Avastin in the first line should be considered to receive Avastin with chemotherapy in the second line. However, it's easy for CCO to say this, they do not fund Avastin second line if you didn't get it first line. again, this is a whole other issue to talk about, and maybe some of these questions will come up later on. And in the third line setting, if somebody is RAS wild type but didn't get an EGFR monoclonal antibody for whatever reason up front, then they should get it in the third line. Next slide. So next slide, BRAF. Let's talk about BRAF very briefly. Next slide, please. So I'm just concentrating on what I put in red here. Forget what's on the right side of the screen. There are a number of studies now historically that have shown us that BRAF mutations tend to confer a poor prognosis on their own, as well as with chemo and an EGFR monoclonal. The response to treatment is less. The overall survival is definitely shorter. And adding an EGFR monoclonal antibody in RAS wild type with a BRAF mutation is not good. Another reason why it's important to have BRAF status up front, because if you have RAS wild type and you get an EGFR monoclonal and you don't know the BRAF status, you shouldn't be getting that EGFR monoclonal. So this is very important. Next slide. So things changed, at least in the second line, with this trial called the Beacon study. This was reported a few years ago. It was a large international randomized phase 3 study. Don't worry about the details of this study. I'm just putting this up to show you that there were 3 arms. The standard arm, which is at the bottom, was the standard chemo with cetuximab. And then, and these are people that had BRAF mutations. Everybody had BRAF mutations. And then the other 2 groups either got encorafenib, which targets BRAF with cetuximab. And then there was a third group that got a third drug added, which is called a MEK inhibitor. What this study basically showed is the first 2 groups of people did significantly better than the standard of care. There was no difference between 2 drugs and 3 drugs, so the winner has become encorafenib with cetuximab. So we have now had this for our patients in the second line for a couple of years, funded by pharma, not Cancer Care Ontario. I don't know what other provinces in Canada have available, but we now have just gotten this available to us outside of a compassionate release program. Next. So just for those who are on this therapy, people need to be monitored for a number of things. There can be dermatologic cancers that can develop, specifically basal cell cancers. So we have to monitor for that. The electrolytes in the blood have to be monitored. Something called the QT interval on the cardiogram can be prolonged. And if it gets too prolonged, it can lead to cardiac arrhythmias. So we have to monitor with ECGs. And there can also be some visual or eye changes, ocular changes. And so if these occur, this requires prompt referral to an ophthalmologist to do a good eye examination. Next slide. Okay, let's talk about microsatellite instability. Next slide. So microsatellites are what we call short, tandemly repeated DNA sequences. We detect them at the molecular level using DNA. And when one gets insertions of deletions of these nucleotides within these DNA sequences, it's what we call microsatellite instability. And when these alterations occur frequently, that's called microsatellite high disease, or the other equivalent is MMR deficiency, because they are due to deficiency in mismatch repair genes. So for our point of view, pretty much MMR deficiency and MSI high are one in the same. Next. And these are characterized by loss of 2 out of 4 possible genes, and this is what we test for. I mentioned them earlier: MLH1, MSH2 and 6, and PMS2. They occur sometimes with a genetic syndrome called Lynch syndrome. Well, this is classic for Lynch syndrome, but it can occur in 15% of sporadic tumors, meaning people with no family history, and 90% of them have at least MLH1 deficiency. Interestingly, from a clinical perspective, they are more common on the right, more common in females. They tend to occur in earlier stage disease, about 15% in early stage disease, about 5% in metastatic disease. In early stage disease, they confer a better prognosis. And in later stage disease, they tend to confer a worse potential outcome. They tend to be poorly differentiated tumors, often signet cell tumors. And interestingly enough, and this is why immunotherapy tends to work in these tumors, is that there's a high degree of what we call infiltration of lymphocytes, a type of white blood cell in the tumor. And there's a lot of mutations in these tumors, making them very sensitive to immunotherapy. Finally, they tend to be more resistant to chemotherapy, which is, again, nothing surprising, but but they tend to be not do as well with chemo. Next slide. So things changed a number of years ago with our understanding of how tumor cells and the immune cells interact with one another. This is a complicated, this is a simple cartoon, but the system is complicated. Suffice it to say that the two individuals who discovered these checkpoints, PD-1 and PD-L1, both won the Nobel Prize simultaneously about 3-4 years ago, one from Japan, the other gentleman was from MD Anderson in Houston. And basically they learned how the cancer cell turns off the immune system. And that allowed us to develop drugs called checkpoint inhibitors, which unlocked this coupling, basically turning on the immune system. Next slide. And this all changed about almost 8 years ago when Dr. Dung Lee reported these findings at the oncology meetings. And don't forget about the third group, just the two groups, MMR deficient or MSI high colon cancer compared to MMR proficient or MS stable colon cancer. And what he found that giving pembrolizumab to these highly pretreated patients, that if you had MSI high disease, the response to treatment was extremely high, 62%, with over 90% of the cancer being controlled. No benefit in patients who are MMR proficient or MS stable disease. And we have learned now that no matter what we've tried to do to try and make MS stable disease more sensitive to immunotherapy, so far we've not been able to be very successful. Next slide. And this ultimately led to this key trial, Keynote 177, which was a randomized trial of people who never were treated with MSI high disease, randomized to either pembrolizumab, one of the checkpoint inhibitors, or dealer's choice chemotherapy, as you can see here. And this was a study that we participated in on behalf of Canada, but it was a worldwide trial. Next slide. And it clearly showed a significant benefit to giving pembrolizumab, which is the blue line, over chemotherapy, which is the orange line. And this, you can see a tail in the curve, even out here, almost 4 years. Interestingly enough, and I've highlighted this here in this red box, that initially for the first 6 months of treatment, chemotherapy, the orange line, did better than immunotherapy. And then the curves crossed and immunotherapy was way better than chemotherapy. What we don't know is who makes up this small percentage of people in whom immunotherapy didn't work up front. It's being investigated, but to date, we really have no way of knowing who these people are that chemo, even if it's MSI high, does better than pembrolizumab. Next slide. Just to remind you that immunotherapy, which is very easy to give, there's no nausea or vomiting, you don't need antiemetics, you don't need hydration. People come into the clinic, the drugs go in over an hour, they come back 3 to 6 weeks later. But there are side effects. And the reason there's side effects is that because we're turning on the immune system doesn't just recognize the cancer cell, it recognizes other normal tissues in the body. And in medicine, we call this itises and inflammation. And there's a whole host you can see here of parts of the body that can be affected. Fortunately, the majority of these are mild. Rarely do they lead to discontinuation of treatment, but it can happen. Some of them can be severe and occasionally life-threatening. Luckily, that's very rare. The majority of these are relatively mild. We can carry on with treatment and nothing terrible happens. Next slide. So I would be remiss if I didn't touch upon the use of immunotherapy for localized colorectal cancer. When this data was presented last spring in the oncology meetings, my phone was off the hook before I even got back from Chicago, based upon, next slide, the study I'm going to show you. So this was a study presented by Dr. Churchick from Memorial Sloan Kettering in New York, looking at PD-1 blockade in patients with locally advanced rectal cancer. So these are patients who did not have spread of their disease. Next slide. And the usual treatment for these people is chemo, radiation, chemo plus chemo, radiation, and surgery. So what this study was, this is a phase 2 study with a drug called dostarlimab, which is another checkpoint inhibitor. It's a newer one, given every 3 weeks for 6 months. And then people who had complete response, at least clinically, were then just monitored every 4 months. For people who still had disease left behind, they then went on to the usual management that we would have given up front which we still do, actually. Next slide. So I'm just going to summarize the key observations. 100% of people had complete disappearance of the cancer in the first 14 that were tested. So only 14 patients, I'm stressing this. There were no significant adverse events. Nobody has yet, at least as of the presentation, needed any chemo, radiation, or surgery. And so far, nobody has had a recurrence of their disease. But the follow-up here was only 6 months, and it's only 14 people. So it's longer follow-up is required. Having said that, next slide. There was a second study presented at the European Oncology meetings in Paris in the fall by Dr. Chalabi from the Netherlands. This is called the Niche 2 study, 107 patients. These were locally advanced colon cancer, not rectal, colon, so higher up in the bowel. And it wasn't randomized. They were all given 2 cycles of chemo. So they were given nivolumab, which is another checkpoint inhibitor. And they were also given something called ipilimumab, which is what we call a CTLA-4 drug. They were given that once. 2 weeks later, they were given nivolumab. And then 6 weeks later, they were operated on. This is the waterfall plot from that study. This is not even a waterfall. This is a lake. 95% of people had a major response under the microscope. Remember, everybody went to surgery, so the pathologist could looked at the cancer. Major response, 2/3, there was no cancer left behind at all under the microscope. So fascinating results. Next slide. Clearly, next slide, please.
I'm trying.
Oh, sorry. Clearly highly efficacious, but there's still lots of questions. Do we use this treatment before surgery? Do we use it after surgery in the adjuvant setting? How long do we treat people for? What is the timing for the response evaluation? Do we use it as a single agent or with a CTLA-4 drug or chemotherapy? Can we predict who's going to benefit? We still need well-designed clinical trials. But the new goal, especially in rectal cancer here, is organ preservation. And that's a key importance for patients with rectal cancer, if we can achieve that. Next slide. So I'm just going to touch upon KRAS G12C. So KRAS, just like BRAF, there's a multiple. So it's not just one mutation. KRAS has a multiple different mutations. Next slide. And the one that we can target today is G12C. It's about 3% of colorectal cancer. There are 2 drugs that have been developed, sotorasib and adagrasib. These work as single agent therapy in lung cancer very well. There's some benefit in colon cancer, but when you add either cetuximab or panitumab to them, they tend to work even better. So this is another specific KRAS. And it's exciting because we've never had anything that we could target KRAS with, which is, as you saw, almost half our patients have a KRAS mutation. Next slide. So clearly we have moved towards a biomarker-driven approach. I'm just reiterating what I've said before. And there's multiple different areas that we can target, but I won't go into this in detail anymore. I think I've said enough about it. Next slide. So key messages. Well-established and emergent biomarker testing is of key clinical importance and will drive selection of targeted therapy. I believe enrolling or referring patients for participation in these trials is important and highly recommended. We have a number of biomarkers that have been approved by Health Canada based on good, positive clinical trials. And the last thing, that's something we haven't even talked about, is that I think all patients should have the opportunity to be discussed at a multidisciplinary tumor board. Next slide. There are barriers that we still have to overcome, not in just testing, but in treatment. And this just gives you sort of a picture of the frustration I think that patients have and that we have as treaters, that there is a patchwork across the country of not only testing when results are available, there's frustration and a patchwork of what happens between provinces, within provinces, and even within the cities that we all live in. Some test on site, some do not. Some have NGS panels, some do not. I hear when I meet with my colleagues that they can't even get BRAF testing. So there's a lot of frustration. And as you've seen, these are all important things that need to get done in a timely fashion. Next slide. This you'll have access to. It's complicated, but one of my good colleagues and friends, Dr. Rachel Goodwin from Ottawa, put this together when I was moderating a meeting, a symposium a few months ago, where things can go wrong if you don't have reflex testing. And all these yellow boxes have all these different areas that things can go wrong. I'll just make one very simple one, and that is, if you have MSI high disease, you're going to get pembrolizumab. You don't need a central line. So there's just one simple thing that people get a central line for no reason. Now, if they're on treatment for 2 years, they may end up running out of veins and need a central line. But up front, we don't need to put in a PIC or a port if we know they have MSI high disease. Next slide. So let me just touch upon circulating tumor DNA. It's a hot area, as you know, and you're going to hear about this later on. Let me just differentiate. There's something called cell-free DNA, and then there's CT, or circulating tumor cell DNA. Cell-free DNA just means DNA fragments that we see in the blood, mostly coming from the blood cells, as opposed to ctDNA, which is fragments of DNA from the cancer cell. Okay, and that's really what we're looking for. Next slide. There are pitfalls with ctDNA analysis. There can be false negatives. There can be false positives. Next slide. But there may be a whole host of applications in clinical practice, anywhere from early detection to assessing response to treatment, for looking for relapse or resistance, etc. So it's a hot area of investigation. Next slide. So I just want to basically say that even though it's exciting, we still need the well-designed clinical trials to provide the evidence and inform the clinical guidelines before I believe this should be widely used in clinical practice. I don't think we're there yet, and I don't think we should be using this routinely on everybody. You're probably going to hear differently this afternoon later on. I won't be around to debate that, but this is my feeling. We still need more health economics work, and we need good collaboration between industry and academic and healthcare systems before we can introduce this. Next slide. So let me conclude. We've clearly made a tremendous progress in the management of metastatic colorectal cancer. We clearly have a long way to go. When I started practice in 1985, the average survival of colorectal cancer once it spread was 6 months. Today, it's at least 3 years, and it can be even longer in those people where surgery can be introduced. And you're going to hear my colleague, Dr. Cypel from UHN, talking about metastatic disease to lung. There are well-established and emergent biomarker testing of key clinical importance in driving the selection of therapy and targeted therapy. Reflexive molecular testing upfront is absolutely mandatory to ensure that patients get treated not only at the right time, but on time with the most appropriate therapy. The role of ctDNA in managing patients with colorectal cancer has exciting prospects. but I still believe it needs to be further assessed in well-designed clinical trials. And finally, I'll just get on my soapbox for 2 seconds. Just because we can doesn't mean we should. Clinical trials are the key to moving the field forward to ensure our patients get the best and the safest treatment. So once again, I want to thank you all for having me today. I want to thank Cran for inviting me, and Philomena. It's a pleasure to work with you, and be happy to answer any questions. I apologize for the beginning.
Thank you so much, Dr. Burkes. That was excellent and well worth it, even though we started a bit late. Ladies and gentlemen, I don't know whether or not you have actually submitted any questions via the chat box, but I do see a hand up, and I do believe it's from, is it from Emma? Is that correct? There was a hand.
I was actually clapping because I appreciate it.
All right. Excellent. Now, Sandy did have a question midstream, like midway. So Sandy, if you'd like to ask that question.
That was an accident that I hit the raise the hand.
Okay. All right. No problem. So let's take a look.
There's a question in the chat here.
Yep, we do. All right. So let's actually, you know what? Let me take a look at some of these questions.
So BRAF, yeah, there's, this is regarding, is there anything that shows benefit in BRAF mutated V600E? Yes, the Beacon study, I mentioned that earlier, was reported, oh God, it's been quite a few years now, but it was a randomized trial targeting BRAF mutated V600E with encorafenib and cetuximab over standard of care chemo, showing probably about a doubling in benefit. It is now the standard of care for patients. In the first line, there are studies that are being done in the upfront setting. Right now, it's reserved for people who've already been treated with chemotherapy.
And another question from Joyce. If someone with stage 3 has new questionable nodules appearing on a CT scan, are they stage 3 with recurrence or now stage 4?
So first of all, we need to prove that those are metastatic disease. You know, sometimes post-surgery, we see nodules, but obviously if they're biopsy proven to be cancer, then that's now stage 4. I mean, they were once you're stage 3, you're always stage 3, but now, of course, they're now stage 4. So, but you still need to prove, just because it's we see nodules, we get, I've been around long enough that I've seen weird and wonderful things happen that have nothing to do with the cancer. We've been picked up TB. So, just because it looks suspicious, you need to prove that it's cancer.
Okay. And Michelle, Lou, I believe you have a question.
Yes. I actually also typed it in chat. So just
for MS.
Yes.
You can ask it if you'd like. Go ahead, dear.
Yes. Just for MSS patients, like what are the new developments for their treatment?
For MSS?
Yeah.
There's really nothing new. I mean, there's lots of there are trials ongoing that are trying to make them more sensitive to immunotherapy, but at the moment, there's nothing that I know of that's ongoing. If you go to clinicaltrials.gov, you'll find a study somewhere where they are being tested. But at the moment, and MSS makes up 95% of metastatic disease. So the majority of our patients, unfortunately, aren't necessarily able to get an immune checkpoint inhibitor. Then there's another question here about KRAS G12V mutations. No, there's really nothing that I'm aware of at the moment. 12C is really the hot area, but give it time, there'll be drugs developed. I think 5 years ago, we never would have expected a drug that targets 12C. So things are changing rapidly, which is why none of us want to retire who've been around a long time.
Yep.
And actually, I have another question. It's for clinical trials. So you're talking about there are clinical trials, but our experience seems to be it's quite difficult to get into clinical trials. And so one of our doctors telling us that only 5% of his patients could get into clinical trials. So I'm just thinking, like, from your experience, how could we overcome this? It's like how make it easier for us to get
clinical trials. Yeah, no, it's an excellent question for sure.
Yeah.
And of course, somebody who does, as a person who does clinical trials, it's important to try and get as many people in as we possibly can. Unfortunately, at the moment, clinical trials are very, very, they're very highly selected, and you got to have, everything has to sort of just, all these boxes have to be checked that people fit the clinical trial. One of the big ones, of course, is they have to be in good shape, good performance status. And that's often one of the big problems getting into clinical trials. I think things are getting easier. I think one of the silver linings of COVID has been improving the ability to get into clinical trials so that people don't necessarily have to come directly down to the center to be monitored all the time. We can do it remotely, and that's hopefully going to improve getting people into trials. I think getting a more targeted approach makes it easier as well, because we have drugs that target certain things, mutations, whatever, fusions, whatever they are. So, we're trying to make it easier for clinical trials. But, I think, and the other thing is, getting clinical trials open in other centers. They don't all have to be downtown at the academic center. They can be anywhere, for example, in Peel Memorial in Brampton, they have a very good clinical trials group there now. So I think trying to get clinical trials closer to home and trying to get pharma, who often sponsors these clinical trials, to think outside of just downtown Toronto or Sunnybrook, getting good clinical trials programs developed out in the community.
Okay. So what's the trial you're talking about? It's Brampton?
So the trial that we're going to be starting very shortly is called the Mountaineer Study for HER2 positive patients. It's a problem, of course, out there because nobody tests for HER2. Our pathologists, if I ask them, they test for HER2 routinely, but I have to still ask them. So we don't even know who's HER2 positive or negative because nobody's testing for it. So we need to at least get it tested for up, quickly. And then, because you still have to have central testing. That's the other problem often with trials, is that people want to get started on therapy. It takes a while to get on in a clinical trial. They have to be assessed. Often, especially with these targeted drugs, the companies want centralized testing, even though we have a positive test at our own institution. It's not that they don't believe it. They want everybody tested in the same location, so there is continuity and there's certain what the results are. So that also takes time. So and sometimes, if a person comes to see me, they're not from Mount Sinai or UHN, getting the tissue from somewhere takes time as well to then send it out to be tested centrally. So all of these are delays in treatment, and people just say, I can't wait any longer. I need to start treatment. So that's,
yeah. Okay, thank you.
You're welcome.
There was one last question, Dr. Burkes, and then perhaps we can move on. If one has mucinous adenocarcinoma of the appendix, does that exclude them from most colorectal cancer trials?
Yeah, that's a good question. That's an excellent question, because I just had this experience with one of my own patients who PMH is doing a G12C study. And I had a patient with an appendiceal carcinoma. They weren't included in that. They weren't allowed to go on that study. Luckily, Dr. Adrian Sasher, who was the other part of the world I live in, which is lung cancer, he is doing a G12C study for all comers. So they were able to get that patient into. He's going to look after that person. But for the colorectal group themselves, usually appendix gets excluded, which is unfortunate because we treat appendiceal carcinoma just like colon cancer. We don't treat it any differently. But unfortunately, the clinical trials who run these trials, sometimes they forget about the appendix.
Yeah. Yeah, for sure. Ladies and gentlemen, I think we're going to, yep, it's 2:15. If you do have any additional questions for Dr. Burkes, we're happy to be in receipt, and we can certainly forward them along with your permission, Dr. Burkes.
Sure, my pleasure.
Yeah, thank you. We cannot thank you enough, Dr. Burkes, for having joined us on a Sunday, no less, to spend time with us today. We are very, very grateful to you. Thank you. Thank you for joining us.
You're more than welcome. Enjoy the rest of the afternoon.
Absolutely. Thank you.
Hey, Marcelo.
So okay, so let's bring this up again.
Hello.
Hello, Dr. Cypel. We see you there. We're just about to introduce you.
Good. Thank you.
Bring up my slides. One moment, please.
I can share here. I think it would be easier.
Yes, absolutely. That's precisely our intention. No worries.
Let me try here.
Just one moment, please, Dr. Cypel. Just one moment.
Okay.
Okay.
Yeah. Okay. I'll take the share now.
Can you see my screen? Okay. Dr. Cypel.
I think you're seeing my screen now.
No, I should not. You should be seeing mine right now because I'm going to introduce you first.
Okay.
Okay. Can you see my screen all right?
No.
We can see your screen, Philomena.
Can you? Okay, great.
Yes.
Dr. Cypel.
Okay, I can. Yeah, I can see that.
All right. Okay. All right, ladies and gentlemen, let's proceed to our second expert speaker, and that's Dr. Marcelo Cypel. Dr. Cypel is a staff thoracic surgeon at University Health Network, UHN, and professor of surgery at the University of Toronto. He is the surgical director of the Ajmera Transplant Center and the director of the ECLS program at UHN. He received his MD in 1999 and completed his general surgery and thoracic surgery residency program in 2004. In 2005, he started his postdoctoral research fellowship at the Latner Thoracic Surgery Laboratory. During this time, he developed a new method of lung preservation and donor lung repair called ex vivo lung perfusion. This method is now used clinically in Toronto and many other centers and has significantly increased the number of transplantable lungs. He subsequently performed a 3-year fellowship in thoracic oncology, cardiac surgery, and lung transplantation at the University of Toronto. During his training, he has received 13 awards, including the McMurrich Award given for the best fundamental science work by any level trainee in the Department of Surgery and the first annual Zane Cohen Clinical Fellowship Achievement Award. He also achieved a large number of first and senior author peer-reviewed publications, including high-impact journals such as Science TM and the New England Journal of Medicine. His main clinical interests are in minimal invasive thoracic surgery for lung cancer, treatment of pulmonary metastases, artificial lung devices, and lung transplantation. Dr. Cypel currently holds the prestigious Canada Research Chair in Lung Transplantation from the Government of Canada, and he is the principal investigator in very innovative clinical trials, such as the use of uncontrolled donation after cardiocirculatory death for lung transplantation and in vivo lung perfusion with chemotherapy to treat patients with lung metastases. He is a member of the American Association for Thoracic Surgery and a fellow from the Royal College of Physicians and Surgeons of Canada. I am very honored to say that Dr. Cypel is a valued member of CRAN's Medical Advisory Board, with whom we work closely because of his patient-centric approach to care. It gives me great pleasure to introduce today's second expert speaker, who will be addressing the surgical management of colorectal lung metastases. Ladies and gentlemen, Dr. Marcelo Cypel. So go ahead, Dr. Cypel, please share your slides.
Yes. Okay, can you see there?
Yes.
Okay, I'll put in presentation mode. Second. Very good. Can you see full mode now? Yeah. Thanks so much, Philomena. It's a pleasure to speak. I'm actually now out of the country this week, so I apologize if for some reason you see some kids walking behind here in this room. I'm going to talk about some of the local management of lung metastases, more specifically from colorectal cancer. It's always a great pleasure to speak here and interact with you and all the patients. So I think one of the main questions when a patient develops pulmonary metastases is whether local therapies are going to be helpful, right? And of course, as you heard in the previous talk from Dr. Burkes, there is a lot of new research being performed to try to treat metastatic disease using systemic therapies. But still, generally, we believe that whenever you can target the lesions, you do get a better outcome, at least with what is available today. And so the modalities for treatment of pulmonary metastases include surgery, stereotactic radiation, conventional radiation, no longer much used, and radiofrequency ablation. And there are a few other treatments that are under investigations that, probably some of the patients are aware of what's called pulmonary embolization and so on and so forth, but it's in a quite experimental phase. And so the two most established ones are by far surgery and SBRT. And when we evaluate a patient to determine if a local therapy is indicated, when I say local therapy, I'm saying, can we actually remove or ablate lung metastases, right? So differently than giving chemotherapy, which is, of course, a systemic treatment. So we look at the patient age and comorbidities, and, we are seeing, I have to say, a lot of the patients with colorectal lung metastases, they are, younger and they are pretty healthy patients otherwise, many of them. So they are good candidates for these therapies. We look at the pathology of the primary tumor. And here is also quite important, the timeline of disease course, okay? So we call disease-free interval. So it's different when someone has pulmonary metastases at the time when they discover the primary, or if the lung metastases develop just a couple of months later, versus someone that had, surgery for the primary tumor or treatment for the primary tumor, and 2 or 3 years later present with a pulmonary nodule, right? So those have different prognostic implications. The number of and location of the metastases are important, because if you have, lung lesions which are more at the edge of the lung, those are easier to treat, with lung sparing approaches, versus if you have a lot of small and deep lesions in the tissue. And then, of course, extrapulmonary disease is also a very important consideration. I'm going to talk a little bit more about that. So yeah, in selected patients, we think that surgery or SBRT are certainly recommended. And, in terms of decision, which one is the best, surgery is a very well-established approach for pulmonary metastases, and we have now a lot of minimum invasive procedures leading to faster recovery and easy, reinterventions if they need. And local recurrence is not common when you get good margins. When I say local recurrence, I'm not saying new nodules appearing. I'm saying cancer coming back in the area of the resection. And it can provide long-term survival. And also it does provide tissue diagnosis that sometimes is important for, mutation testing and so on and so forth. Surgery is not perfect, and even the minimum invasive surgery can lead to some complications with some prolonged pain. For example, you can have local recurrence, you can have pleural dissemination, and you can have loss of lung function when you have larger resections that are required. So this is just an example here that you could have, this is the staple line of a previous resection, and you see there is a growth back here close to the staple line, and similarly on this area here. So, it can happen, and that's why the margins are very important when you do the resection of these lesions. Some patients could present also with pleural disease after surgery. This is an example here. You have this nodule here that is already kind of touching the pleura, and then you do the surgery, and later the patient presents with pleural disease here, which then becomes very difficult to treat, right? The question here is this pleural disease developed as a result of surgery, or this lesion was already contaminated the pleura even before surgery, and this just took some time to develop. It's difficult to tell. Of course, we're always very careful with the manipulation of these lesions in the chest. And we're doing some studies now that we're kind of doing a pleural lavage to try to determine whether there are cancer cells in the pleura, even when we can't see anything, and which may also help, to stratify the risk of the patients to develop this. In terms of stereotactic radiation, it's very well tolerated, and patients can work while on treatment, and they have minimal side effects, about 3 to 5 days treatment, and does not preclude other treatments immediately, such as surgery or SBRT. But I think the cons for SBRT are mainly the recurrence rate, about 20%. In fact, in colorectal cancer is one of the highest rates of failure from SBRT. So, for example, in sarcoma, we see about 10 to 20% of recurrence after SBRT in the area that was treated. In colorectal, that number is more like 30, 35, 40%. Some of the studies from MD Anderson showed that. So the colorectal cancer seems to be more resistant to SBRT than some of the other tumors we treat for pulmonary metastasis, but still, has a reasonable chance of cure that area. And you can have rib fractures for peripheral lesions, and the feasibility depends on the location and size. Ideal treatments for SBRT is somewhere between 7-8 millimeters to 3 centimeters, although now they are treating lesions bigger than that. And rarely you can do efficacious repeated treatments. And so if it fails once, usually the radiation oncology will send the patient for us for consideration of surgery. And of course, if patients have other lung diseases like a degree of pulmonary fibrosis, is usually contraindicated because you can exacerbate that. So, these are lesions that are a bit of a challenge for SBRT. You can see this large lesion here in the left lower lobe. It's very close to the bronchi here. So you could cause some bronchial injury and narrowing of the bronchus, which will cause to the patient a lot of symptoms and really, more symptoms that they would get certainly, with surgery. in this case here, the lesion is very close to the rib, so you could get a rib fracture. I have a patient that did have a rib fracture post SBRT, and that can cause a lot of pain. And then when lesions are too small like this is also a challenge for SBRT. So, this is one example of, again, SBRT failure. So you treat it here, and then 6 months later, the lesion is bigger. So this can happen. And also in this case here, that you treated the lesion in 2016, you can see there is just some scar in 2017, but then back in 2018, it's growing again. So this can happen. Again, it doesn't happen in most of the time, but we have to keep monitoring these areas. As I mentioned, there is an option for salvage surgery. If the SBRT fails, you can go and then resect, assuming that there's no development of widespread, disease. And as I mentioned, this was my patient that had this lesion here, and then he received the SBRT and had this rib fracture, and she had a lot of pain with that, requiring the use of opioids. So, it's a very well tolerated treatment, overall, but there are some risks of complications, especially depending on the location of the lesions. Now, in terms of the general principles, if you look at, for all comers that undergo surgery for pulmonary metastasis for colorectal cancer, generally the 5-year survival is about, 45%. Okay. So again, there are patients that, this is just an average. So patients, have much better survival than that, or much worse, depending on some features. And one of the important features here is whether they receive a complete resection. So complete resection means that you either remove or treat all the lesions. When I say remove or treat, because sometimes we do a combination of surgery and ablation therapies like SBRT, but you do have to target all the visible lesions, right? It's not really helpful if you say someone has, let's say, 8 lesions, and you say, okay, 4 of them are easy to treat, so I'm just going to treat those 4. That doesn't provide benefit when we compare to continue just systemic therapy, for example. Okay, so this is very important to understand. And the number of lesions is also important. So if you have more than 3 or less than 3, there is a prognostic factor on that. So if you have less than 3 lesions, we have a better prognosis. But again, there's many other features that are important in terms of the biology of the tumor itself, and also the biology of the patient and the immune response from the patient against the cancer. These are some of the important prognostic factors, again, for surgery. So you can see here the risk ratio here, okay? So, some things increase a little bit your risk. For example, a past history of extrathoracic metastasis, increase, but not a lot. It's just like 1.2, right? So this is very important because many patients do have, liver metastasis, for example, or they may have, 1 lesion in the bone or 2. And so if you have extrathoracic metastases and you treat those, then when you go and do the surgery for the lung, that doesn't, having had those extra pulmonary sites, do not greatly impact the outcome of these patients. Okay, it does impact a little bit, like 1.2, but it's not a lot. Same thing, CEA, high CA, a little bit of adverse impact. And if the maximum lesion has more than 2 centimeters, also it may have a little bit of an impact, but nothing much. What really matters here, and you can see 8.2, that's a big risk difference, is if you have lymph node metastasis in the chest, okay? And so that's when we see some patients that come to us for surgery, and we see lymph nodes enlarged in the mediastinum, and either we prove that they are malignant with a biopsy or a PET scan, and those are patients that surgery, there is no data really to show that surgery would help the general outcomes of these patients. So we tend really not to indicate any local treatments or I'd say curative local treatments in those cases. Now, interestingly, if you do have repeated pulmonary metastases, you do better. And so this just saying that, let's say you had your surgery for pulmonary metastases, and let's say a year or 2 years later, there is another couple of lesions. If you go back and do surgery, that helps as well the prognosis of the patient. And this here showed in red, again, patients that have repeated pulmonary metastases, they tend to do better than patients that only had one, for example, here. And again, there is also a selection bias here, because maybe the ones that we don't go back are the ones that had, multiple new lesions or some other adverse effects. Now, there has never been really a randomized trial that, someone present to clinic with, let's say, 3 or 4 lesions, and you flip the coin and say, you going to be randomized for surgery, or you going to be randomized for medical therapy. Medical therapy meaning continue on systemic therapy. And the main reason is because it's very difficult, or has been very difficult, to convince patients that are surgical candidates to just continue on medical treatment. And so the trials, this was a UK trial that tried to enroll patients, and they couldn't really enroll many patients. There were very, very few patients included. They wanted to enroll like 500 patients, and they enrolled at the end, 28. So they couldn't get to any conclusion from that standpoint. Now, when you look at surgery versus SBRT, there are also no comparison results. Generally saying SBRT has good local control, about, as I mentioned, 70 to 80%. But this study that compared either SBRT or surgery via wedge resections, it did show that that surgery had a decrease in the rate of recurrence. As I mentioned to you, again, this is a study from MD Anderson. We had up to 40% of local recurrence in the SBRT treated site up to 5 years after treatment, whereas in surgery, the maximum was 20%. So in general, we still prefer surgery whenever you don't need to resect, a lot of lung or if the patient is in a good condition for that therapy. So, in general, if they provide relatively similar local controls, how do we select? We maximize treatment efficacy and try to decrease morbidity. So we're always trying to balance those two issues, right? We want to provide benefit with the less morbid approach possible. And it's highly patient-specific, and it's not always either or. And so we have probably the only lung metastasis clinic in North America here at Princess Margaret, and almost 100% of the lung metastasis patients are referred to this clinic. And we always have a multidisciplinary discussion with 2 surgeons, radiation oncology, the referring physician, med onc, thoracic radiologist. And it's very important to review, because very often we may find more lesions in the imaging review that has been reported on the CT scan. And the plan is made in a multidisciplinary fashion even before seeing the patient for the first time. And when we consider, for example, SBRT, so if a lesion requires a lobectomy, which means removing like a whole lobe of the lung in a patient with a high chance of future recurrence in other parts of the lungs, we want to spare the lung, and then that would be a good indication for SBRT. If we have multiple lesions where a minimally invasive surgery would be possible, if some of the lesions are treated with SBRT, and of course, patients with multiple medical comorbidities, we would favor SBRT as well if it's not a surgical candidate. So just a few examples here. So this is a 54-year-old male with colon cancer 18 months prior to this CT. And here he has one lesion here, one lesion here, and one lesion here. So 3 lesions. And, these lesions you can see here, they're very peripheral. They're in outer part of the lung. They're very easy to remove with camera surgery. We're sending patients home now in the same day after this surgery. When you look at this lesion here, it's a bit deeper, and that becomes a little bit more difficult to remove with surgery, although it's still quite possible. And so this is another patient, that 76-year-old, 2 years prior colorectal cancer. And he had this lesion here and this on the right side and this in the edge of the left lung. And so this is a situation where we say, he's 76, let's try to spare surgery on one of the sides. So we gave SBRT to the right side lung lesions, and we did a VATS surgery, minimally invasive surgery, to the left side. 6 months after treatment, you see this scar here in the area of the SBRT treated. This is the scar of the surgery, the staple line here. And sometimes this can be a little bit of a challenge here on the SBRT scar, because you have to monitor these because you don't know if there's still maybe some viable cancer cells there that it may recur. This is another situation with multiple deeper lesions. This is a good case that we combine surgery for some lesions and SBRT for other lesions. As I mentioned here, this patient received SBRT while I was waiting for surgery and then received surgery. This is a different type of cancer, but again, the concept is the same. Endometrial cancer, one lesion here in the middle of the right lung, and one lesion here on the left. And we decided to do SBRT on the right side and a VATS segmental resection on the left. This patient received this treatment now, has been 8 years, and she's still free of disease. So it was very, very effective treatment. And this is a situation that I mentioned before. So this is a patient, again, with one lesion here, small lesion, but it's in the middle of the lobe here. And unfortunately, to remove this lesion with good margins, we will need to remove the whole left lower lobe. So that's a situation where we may, after discussing with the patient, we may consider doing a non-surgical approach in order to not have to remove the whole lobe, although you can live completely normal, removing a whole lobe. We do this all the time for lung cancer patients, but we still, in a metastasis setting, we try to spare as much lung as possible, because we know that maybe in a year or 2 or 3, we may need to do more surgery. And so, that's the general concept we have. And again, this is a scar post SBRT. So in terms of the conclusions for these, both surgery and SBRT results in good local control and low toxicity in well-selected patients. And we don't have randomized data to show which one is superior, although the data, retrospective data suggests surgery perhaps is a bit better. We are planning to do a randomized trial at UAGN, not only for colorectal, but for all patients presented with, metastasis to the lungs. and try to answer that question. And the patient selection is the most important. Having a multidisciplinary discussion is critical. Now, in terms of the results of surgery, again, we talked about minimal invasive surgery or open surgery. And again, we try to do minimal invasive whenever it's possible. And usually, I would say patients with 3 or less lesions are the ones we would consider for a minimal invasive approach. We looked at the data from VATS surgery versus open surgery. And again, we didn't see any significant differences in survival. So this was 211 patients that received surgery for colorectal cancer in our hospital, in which 35% received minimally invasive and 65 had open approaches. Open, when I mean, is thoracotomy. Again, there was no difference in survival. Again, we had a fairly good survival compared to the literature, in the range of 50 to 60% 5-year survival here. And the chance of recurrence in the treated lung was about 20 to 25% and were similar in both groups. So the most common and accepted VATS indication are either 1 or up to 3 lesions, and we tend to perform VATS whenever possible. But at the end of the day, we also have to consider the tumor biology, and surgery or SBRT have to be regarded as part of combined efforts to control disease progression. And then, just the last part of this presentation, I'm going to talk briefly about why we go and do surgery, and oftentimes we fail. Fail means that new lesions show up, in the subsequent months or years, and that's probably because these patients already have clusters of tumor cells in the lung, what we call micrometastases, and we just can't see those with surgery. Or any modality of imaging at the moment. And so although we go and remove this nodule here, we know that there may be some cancer cells already in other parts of the lung here, and we can't see. And so that's the concept about doing in vivo lung perfusion, is that during the time of surgery and removal of these lung metastases, we would give a perfusion of the lung with chemotherapy to try to eliminate these other sites of disease. So I can probably show you a quick video of that soon, but this was developed as an extension of some of the technology we developed for lung transplant. But basically, we isolate the lung from the blood circulation. And so we can give higher dose chemotherapy. And because the vessels are not communicating with the patient blood during the chemotherapy delivery, there is no leakage of chemotherapy to the circulation. And so this is a treatment that is specific for the lung. Now we are doing with chemotherapy, but I do envision that maybe in the future we can use this technique for, biological approaches or gene therapy and other things that could be more effective even than chemotherapy. So, this patient was a sarcoma patient that was one of the first treated. We started this with sarcoma. And then we more recently, we started with colorectal cancer. We did initially these studies in the preclinical setting. This was done in large animal studies just to determine the safety and some of the dosing that we could start doing in humans. And then we recently started a phase 1/2 clinical trial that is this one here that you probably can see if you go to clinicaltrials.gov. And we have already recruited 2 patients. So we started basically, the first patient was done early February. The second patient was done in March. Both patients recovered well. I mean, the first patient is already a month off, and I just spoke with him last Friday. He's doing well. The second patient, we did the surgery last week, and he's probably going to be discharged home tomorrow. Also recovering well, but again, it's just been a week from the surgery. And we, one of the things is that this study is a dose escalation design. So we are increasing the dose quite slowly of the chemotherapy because if we see a lung toxicity, then we have to stop, right? And then go back to the previous dose. And then eventually, once we determine which of these doses is the right one, we're going to then expand the study and doing both lungs. Right now, we're only doing one of the lungs, and this is more for a safety perspective. If you do get a lot of lung inflammation, that is not life-threatening because your other lung is normal and not affected. And the lung inflammation is totally related to the dosing that you use. So that's why we're, in that dose escalation phase now. So I think I'll stop here, but I'll be more than happy to, answer any questions. Thank you.
That's great. So can you stop? Yeah, perfect. Excellent. So ladies and gentlemen, I'm assuming that you have questions for Dr. Cypel. Okay. So do we have any? I see we don't have any questions in the chat box. Do we have questions that you'd like to ask him yourself? Parviz, do you have a question for him?
It is in the chat box.
No. Would you like to ask him a question? Because I saw.
Because
yes,
according
please.
to Dr. Burkes, the people who have metastasized for the CRC might have 3-year survival rate. Is that the exact figure, or what do we think?
Dr. Cypel?
Well, I think it's. 3 years. It depends a lot, right? Each patient is so different. There are many patients that have metastatic colorectal cancer that they have surgery in the lungs and liver, and they are cured. So you can't tell that that's the case. The 3 years is the case for every patient. I think it's probably referring as an average for patients that are unresectable, that continue on systemic therapy, and that's probably an average figure. Yeah.
So the next question is, I may have missed this, but can SBRT and/or surgery occur concurrently with systemic treatment?
We normally would like the chemo to be stopped for a brief period of time before surgery, just for the patient, to have an easier recovery. But usually, I would say you stop for about 3-4 weeks prior, and then you have the surgery, and you can go back very quickly after. Again, depending on the magnitude of the surgery and so on, but most patients are fully recovered, in a matter of a few weeks. Unless you have very extensive disease in both lungs that you need open surgery on both sides, then you may certainly need longer to recover. But yeah, it can be done almost concurrently with a brief stop.
And how long does the in vivo procedure take?
Yeah, so the surgery takes about 6 hours, okay? Because once we start the chemotherapy perfusion, is about 3 hours of perfusion. So just that part is 3 hours. Then you have to add the anesthesia time and also the part of the surgery for removal of the lung lesions. So if you're doing on both sides of the chest, the surgery, then it will take, the whole surgery takes about 6 hours. The lung perfusion itself takes 3 hours.
So there's a comment, Dr. Cypel. Luke is doing so great. In vivo lung perfusion is innovative. Thank you, Dr. Cypel. So you have completed 2 in vivos, is that correct, Dr.
Yes,
Cypel?
yes, and we have already patients booked for. So we're basically doing 1 patient every month now.
Mm-hmm.
Okay. And I mentioned I cannot do more than 1 because I do have to see that the patient is doing well at 30 days before I can do the next one, because we're changing the dose, right?
Right.
That's why we cannot. I mean, eventually when we define the safe dose, then of course we could do then more patients in a month, right? So
yeah, that was going to lead me to my next question, which is, at what dose are you currently? Are you still at 5 or at 10 milligrams?
No, we did the first at 5, then the second at 10. Yeah.
Okay. Yeah,
and
so
then we're going to evaluate the 10 now.
Yeah.
If we are totally happy in terms of the X-rays and other things, we move to 15. Right. Otherwise, we do another patient at 10. Okay. Because sometimes there could be a little bit of lung inflammation, but you have to remember that some of these patients, we have to remove a lot of lung nodules. Mm-hmm. So the appearance in the X-ray sometimes is not that clear if the changes on the X-ray is because of the surgery itself or because of the chemotherapy, right?
And is that how you're evaluating, through X-rays, Dr. Cypel?
Yeah, mainly through X-rays, yeah.
Okay.
Yeah, and X-rays, yeah.
Okay, all right. The next question. Sorry, the next question is, if you already had a wedge resection, can you have the infusion for any possible micrometastases?
I mean, you theoretically you could, but again, it's probably, I would say it's probably better to wait and see, because if you do develop new lesions, then we can do the surgery and the infusion at that time. But I don't think I would do that as a totally preventive strategy at the moment, because it's still an invasive procedure, and so it's more compelling to do if you have lesions that we will remove at the same time.
All right. And how amenable to ctDNA tests is lung cancer? I'm assuming they're talking about lung metastases from colorectal. I understand that tissue quality procurement can be a challenge.
Mm-hmm. No, I think, as Dr. Burkes mentioned, I think, ctDNA is very well developed now in lung cancer, and I think it's developing in colon cancer as well. But I think, taking from blood, I think you can measure that. The main question is, what do you do with that information, right?
Yeah.
And, just to give an example, I think will be very helpful for us to manage these patients, because one thing that people always ask, after you remove the lung metastasis, should I go back on chemotherapy, right?
Yeah.
And the reality is that there is no data to say you should, normally we would say probably better just to monitor now if you don't have any visible disease. But maybe the ctDNA is the part that will screen the patients, right? So you do, let's say you remove your lung metastasis and then you measure the ctDNA in blood and you still have positive ctDNA, maybe those patients should go back on chemo, right? versus the one that the ctDNA disappears after surgery. Those probably should be under just surveillance. That's how lung cancer field is evolving. I think that's how colon cancer field will evolve as well.
Yep. Any other questions, ladies and gentlemen, for Dr. Cypel? I'm sure that if you come up with any additional questions post-session, he would be very happy to take them. We would be happy to forward them along to him. He's always very happy to entertain additional questions. Okay, all right. Dr. Cypel, we're so grateful to you for having spent your time while you're on vacation, no less. We're truly, truly grateful. We wish you an absolutely outstanding rest of your vacation and Sunday. Thank you for joining us today.
Thank you. Yeah, have a good Sunday, all.
Thank you. Okay, so let's bring up to my presentation. Well, I've got multiple presentations going on here. Okie dokie. All right, ladies and gentlemen, I'm going to introduce our third speaker. Okay. Hi, Felicia, are you there?
Yes, I'm here. Hello.
Hi, welcome, dear. Welcome. Okay. So I'm going to be introducing our third speaker, and that's Ms. Felicia Newell. Felicia Newell is CRAN's National Registered Dietitian. She has a bachelor and a master's degree in nutritional science and has worked in areas such as research, education, healthcare, and private practice for many years. Felicia oversees the expansion of CRAN's My Foods for Life program, in addition to the development of a primary and secondary cancer prevention program. In addition, Felicia is honored to support the nutritional needs of CRAN patients and is passionate about helping patients meet their nutrition needs and manage symptoms in a realistic and manageable way. I'm very pleased to introduce to you Ms. Felicia Newell. Felicia?
Thank you so much. Thank you. I will attempt to share my screen here. So we'll just make sure that that gets up and running first. I'm honored to be here and happy Colorectal Cancer Awareness Month, everybody. Okay. Actually, I'm going to stop and then restart again because there is a couple quick videos in my presentation. And I realized in order for you all to hear the sound, I have to click share sound before I share my screen. So I forgot to do it then, but I have done it now. So hopefully, fingers crossed, they should work. And now I need to go and present. Can everybody see my screen so far?
Yes, yes.
Okay, perfect. So there we go. Okay, excellent. So very happy to be here today. Thank you so much. I will say, I did put a lot of content in this presentation because, I don't feel that we truly, absorb all of the information that we hear in, 45-minute to an hour period. So it's nice to have this kind of as a resource as well. So I absolutely don't mind sharing the link or sharing a PDF version for anybody who would like a copy. And my email and contact information is at the beginning of the presentation, at the end of the presentation. If you have any questions at all, or if you'd like to reach out for support, you can email me, or if you forget my email, you can always reach out to Philomena or Cassandra and they can forward you along to me. So today I wanted to talk about the nutrition goals during treatment for the metastatic cancer population. And we're going to talk about a few different categories. Again, it's a lot of content. I feel that each of these categories, or at least most of them, could have a presentation in and of itself. So I really wanted to give some high level content for each of these categories that I feel are important for patients to know, and are a lot of the time information that I discuss with patients. So again, if you have any questions at all afterwards, please don't hesitate to reach out. And I do want to leave time for Q&A at the end. So if you have any questions kind of as we're going along, you can put them in the chat, and then I'll try to answer as many as I can at the end of the presentation. Okay. So nutrition is, of course, important for everybody in general, and especially cancer patients, but it's not just about consuming nutritious foods and beverages. It's really important that your body absorb the nutrients in order to benefit from them. The main function of the colon is to absorb electrolytes and fluid, but colorectal cancers and their treatments may impede nutrient absorption for various reasons. Treatment for colon cancer patients may include having to have part of the colon surgically removed, leaving patients with needs that are different from patients with other types of cancer. So we'll talk about these things today. So as Philomena mentioned, CRAN has developed My Foods for Life program, and the second part of that program talks about after diagnosis and beyond. So a lot of what we'll discuss, a lot of what I will discuss today will be in that program. It's a resource that's available on the CRAN website that Cassandra can provide to you, or I can provide to you. And we really hope to be expanding on it over the next little while. So we're going to talk about, how we can really get this information to patients more. So if you have any ideas, I would love to hear that. But there's lots of helpful diet-related tips that can help you manage side effects before, during, and after treatment, and then goes into the various, nutrition goals and guidelines as well. And we know that eating a well-balanced diet before, during, and after your treatment can help you feel better, maintain your strength, and speed your recovery. Obviously, being faced with a colorectal cancer diagnosis can be very overwhelming, and it's often difficult to know where to start. And I'm sure there's lots of different and conflicting information sometimes coming at you. There also may be times when you are too unwell to eat what you might perceive to be quote unquote perfect, which, some people may think, oh, I have to eat completely clean, quote unquote, which we'll talk about later, and follow each and every guideline. But please try to remember that these are just general guidelines to work towards. What you consistently do over time matters most, and each and everyone's cancer journey is going to be unique. So try not to compare yourself to somebody else and their journey. Again, your nutrition needs during your cancer treatment may be different than at other times in your life. And the purpose of nutrition during treatment is to keep your body strong enough to heal and recover optimally during and after your treatment. Getting enough calories, protein, and fluids, which is kind of, some of the main nutrients that I tell people to focus on. We'll talk about a few other of the nutrient categories later, but even if you're overwhelmed and you really don't know what to focus on, especially going through treatment, getting enough calories, protein, and fluids can help reduce the risk of malnutrition, maintain strength and energy, maintain weight and muscle mass, lower chance of infections, cope with side effects of treatment, lower risk of admission to hospital, complete your treatment as prescribed, heal and recover faster, and maintain a healthy relationship with food. That's something that we'll talk about later in the presentation as well. So again, if you want more detailed information, including sample meal plans and recipes, you can go to cran.org or send me an email and I can send you the full resource. So many cancer patients in general are at risk of malnutrition and dehydration as well, but those with gastrointestinal cancers, which includes colorectal cancer, are even more likely to experience some degree of malnutrition. Also keep in mind that a higher body weight does not mean the risk is not there. I often hear people either say, maybe they're in a larger body or they weigh 200 plus pounds, and they say, oh, I got some weight to lose, that's fine. But when you're going through cancer treatment, it's really important to know that even if you're in a larger body, there is still a risk of malnutrition. So it's something to some people are lightweight, some people are in a larger body, and be risks for malnutrition.
Sorry to interrupt there, Felicia. I think you're cutting in and out a little bit.
I saw that there, and I think it has to do with my AirPods. Can you hear me okay now?
I can now, yes.
Okay, because I kind of got a message come up on the screen that they were connecting and disconnecting. If that happens again, I might just change it to my computer speakers, but for now, I think we're okay.
Okay.
Cancer, sorry.
Sorry, do you mind just repeating that last little bit that you said there?
Sure. I'm not quite sure what you did and didn't hear, but I was basically saying that even patients who are in a larger body are still at risk of malnutrition, because I hear a lot of people say, you know, oh, I could stand to lose a few pounds, or I work in long-term care sometimes, and some of the staff there will say, oh, well, this person lost weight, but I didn't think to tell you because, you know, they could stand to lose a few pounds, right? They make those assumptions, but even people in larger bodies are at risk of malnutrition, especially when it comes to cancer and colorectal cancer. So please keep that in mind. Because malnutrition can lead to several negative consequences, including poor prognosis, reduced survival, increased therapy toxicity, reduced tolerance and compliance to treatments, and diminished response to certain drugs. So getting proper nutrition during treatment is obviously very important and can help maintain a healthy weight, muscle mass, and energy levels, all of which contribute to the ability to tolerate cancer treatment and prepare for survivorship. So again, unintentional weight loss is kind of, it can be a symptom of something underlying. And sometimes it's just, you know, the nature of the type of treatment, medications, loss of appetite. But cachexia is sometimes the underlying issue, and it's a term to describe a complex, life-threatening metabolic condition that can lead to unintentional weight loss and contribute to loss of appetite, muscle wasting, and fatigue. It's often experienced along with certain chronic illnesses, such as colorectal cancer, but this risk is even more increased for patients who are in stages 3 and 4. With cachexia, metabolism is increased, meaning that you just naturally need more calories and fuel daily, and appetite is lost. So that's kind of, you know, those two are obviously competing. So it can be, you know, it can be very difficult, but hopefully with some of the tips throughout this presentation, you can learn how to increase your calories and protein, even when you're feeling that loss of appetite. Loss of appetite and loss of muscle are often early signs of the syndrome that need to be addressed. So again, sometimes it's complex where you think that loss of appetite, loss of muscle might be due to some of the treatments that you're going through, but it could be due to cachexia. So it's important to work with your registered dietitian and your healthcare team to kind of talk about any symptoms that are happening. And the cancer treatment in and of itself will help to treat cachexia, and focusing on nutrient-dense foods when you can also help to mitigate its impact. So again, a goal really should be to avoid any significant unintentional body weight loss, such as more than 5% of your body weight. Calorie needs will, of course, vary. Even for the general population, they can vary based on age, height, gender, activity level, but also the factors previously mentioned, such as, is there cachexia happening? Are you recovering from surgery? Are you going through chemotherapy? All of these things can affect your daily calorie needs. But in general, if I were to estimate, you know, having calculated daily needs for lots of different types of patients, on average between 1,800 and 3,000 calories. Women tend to need less than men. So, you know, they're usually in the 1,800 to 2,000 range. Men usually 2,500 to 3,000 or more. And again, activity level could affect this as well. You could be still quite active if you were active before your diagnosis and you're feeling good and you're staying active during treatment. So yes, all of those things obviously have an impact. Fat should be around 25% of your total calories, so around 50 to 80 grams, depending on your daily needs. People tend to not have a lot of issues getting in enough fat because it can be very calorie dense, and it's easy to add to things like, you know, cheese or nuts or seeds or olive oil, things like that. They're easy to add, and the calories add up quickly because fat's very calorie dense. But protein people tend to struggle getting enough of, and cancer patients have increased risk to help reduce catabolism, which is the breakdown of muscle tissue. Again, the recommendation varies. It could be slightly lower, it could be higher, sometimes even up to 2 grams or more per kilogram of body weight, depending on, again, if there's cachexia involved or if there's, surgery, recovery, things like that. But on average, for the average person going through cancer treatment, around 1.5 grams per kilograms of body weight would be sufficient for protein. Some other general guidelines during treatment, if you're having minimal side effects and you're feeling well, most patients, when they come to me, they're, and we're going to talk about a healthy relationship with food towards the end of the presentation, but a lot of people come to me and they're scared. They're scared about food. They're scared about their diagnosis in general. And we know there's a lot of misinformation online, and sadly, misinformation tends to get more views, more engagement. It can sound really compelling. So a lot of people, when they come to me, they really strongly want to follow the guidelines and eat, again, I put this in quotes, but eat very clean, no sugar, no alcohol, things like that. And for some people that might be realistic, but and again, we're going to talk more about this throughout the presentation, but just please keep in mind that these are general guidelines, and different things are going to work for different people based on your access to food, your income, all these different things. So if you can't meet the guidelines fully, then that is okay. What's going to matter most is what you're doing 80% of the time, 90% of the time. And, if once every 2 weeks you order pizza because you have nothing planned, I mean, that's not what's going to reflect on our health. What's going to reflect on our health is what we're doing, again, consistently over time. So I just wanted to kind of say that up front first. But in general, the guidelines are, eat a diet rich in fruits and vegetables and higher fiber foods such as whole grains and beans. Ideally, we want to aim for 7 to 10 half-cup servings of fruits and vegetables combined, which I know sometimes sounds like a lot, but a lot of the time when we're having vegetables with our meals, like we'll tend to have a full cup of veggies. So that's 2 servings there. And I always tell people, just add on to what you're currently doing. If you currently have your regular meals and you already have a cup of veggies with supper, then maybe just add a little bit more, have a side salad with it, or have some fruit after your meal. Because sometimes that's a little bit easier to do than trying to add in extra snacks throughout the day at times where you're not really used to eating. For fiber, women need about 25 grams of fiber daily. Men need 35 to 40. I will say that many people do not get enough fiber. And there is certain instances during your cancer journey where you might need to eat a lower fiber diet. We'll talk a little bit more about some of that later in the presentation, but sometimes when you're preparing for surgery, you'll be asked to go on a low residue diet or clear fluid diet. But these are supposed to be short-term changes. For the most part, we really do want to work on increasing our fiber because there's so many benefits, not only for gut health, but for heart health, for cancer prevention, and many people don't get enough fiber. So there's just so much emerging research at the importance of getting enough fiber. We want to limit the consumption of fast foods and other ultra processed foods that are high in fat, starches, or sugars. Most of the recommendations, the American Institute of Cancer, Canadian Cancer Society, are just to limit. There's not really a specified amount because the term processed food is subjective in and of itself. But ideally, we want to keep these foods to within 10 to 20% of our overall diet. And just do your best to, I like to focus on addition versus restriction. So just focus on adding in more nutritious foods and reducing the amount of ultra processed foods. Limit the amount of, the consumption of red meat to around 12 to 18 ounces per week, and limit or avoid processed meats altogether, like your bacon, bologna, sausage, things like that. Again, this is more realistic for some than others. For some people, eating a plant-based vegetarian diet is realistic. They enjoy that. But some people do really like to enjoy incorporating meat in their diet. And that is completely okay. again, it's, as with anything, it's the dose that makes the poison. And, what we're doing, again, 80% of the time, if you're focusing on increasing fruits and veggies, adding plant-based sources of protein, such as nuts, seeds, beans, chickpeas, and reducing consumption of red meat to, within the allotted guidelines, then that is okay. Limit the consumption of added sugar, including sugar sweetened beverages. Aim for less than 24 grams of added sugar daily. But please keep in mind, this does not include natural sugars. I get a lot of people, there's a lot of confusion with this, of course, because our nutrition labels do not distinguish between natural or added sugars, and also misinformation out there online about natural versus added sugars. But the guideline is for added sugar only, and natural sugars such as those found in fruit or dairy, those do not need to be limited in most cases. Limited consumption of alcohol to no more than 2 drinks per day for men and 1 drink per day for women. There is emerging guidelines that, the more we can limit alcohol to even less than this, it's going to help to improve chances of survivorship, or, reduce the risk of recurrence. So just try to limit as much as you can. I know, again, it's more difficult for some people than others. Include 4 to 5 servings of anti-inflammatory fats daily, such as nuts, seeds, and avocado. But again, these can be very small amounts. A half avocado would be 2 servings. A thumb or a tablespoon of olive oil is 1 serving. So, again, fats are more calorie dense, but they're very important, and especially anti-inflammatory fats, unsaturated fats such as these are really important to include in the diet. Sorry, I'm just going to have some water. So, of course, as I've been saying, each patient is unique based on their situation, and some patients have pre-existing conditions such as heart disease, diabetes, Crohn's, colitis, celiac, diverticulosis. I've worked with patients that have, all of these, or not all at the same time, but various conditions such as these, and that's going to, of course, affect your nutrient needs. The stage of disease that you're in and the treatment process, of course, is going to affect how much calories you need, the protein you need, side effects. We're going to talk about symptom management in a few slides. If you're going through surgery, if you have an ostomy, I added chemo and radiation again, but those, of course, are going to impact your needs. So just aim to stay hydrated and eat nutrient-dense foods that are high in proteins, vitamins, antioxidants, and electrolytes, and try to achieve adequate calories and protein. And if you have any specific questions or needs based on the above or any other factors, working with a dietitian can help. So you may have a dietitian as part of your regular healthcare team, and that's great. But if you don't, or if there's a long wait list, then you can always reach out to me as CRAN's national dietitian for one-on-one support as well. So I just wanted to give some examples of food sources of protein. This isn't an all-inclusive list, but just different sources of, your lean, nutritious sources of protein. Obviously, again, with the red meat, we do want to limit that to within the guidelines, but there's other types of protein out there that people don't tend to think about or incorporate into their diet, such as your nuts, seeds, beans, peas, lentils, tofu. Even nutritional yeast is great, and a lot of people don't know what that is. So yeah, if you have questions, it's always good to ask, because there are ways that you can increase protein without necessarily having to increase the amount of meat that you're consuming. And again, your goals may vary. So if you're unsure exactly how much protein you should be consuming daily, then a registered dietitian can help calculate that for you. And these are just some examples of nutritious fat sources. Again, your really anti-inflammatory fats are going to be your nuts and seeds, avocado, oils such as olive oil, avocado oil, Even fish, so omega-3 fatty acids are something that we cannot produce on our own and we need to obtain through food. And they have excellent anti-inflammatory properties. And I find it varies. Some people love fish, they get it in their diet, and we do absorb omega-3 more efficiently from fish sources because there is omega-3 in, flax seeds, chia seeds, walnuts, but we have to convert the ALA and those sources to EPA and DHA, and our body is not always efficient at that. So not saying that some people just for their own preference do not like to eat fish or seafood, but if you don't, then it'd be really important to try to get in omega-3s in other ways, such as eating more of the flax seeds, chia seeds, walnuts, things like that, and just making sure you have a lot of eating it daily, multiple times a day, just to make sure that you are getting the omega-3s from there, or taking a supplement if that's something that you find is difficult to do. These are our fiber-rich carb sources. Again, not all-inclusive. Really, any fruit or vegetable is a good source of fiber. I only have a few examples there, but we do want a good mix of what we call soluble and insoluble fiber. So while fruits and veggies are great sources of fiber, we want to get some softer soluble fiber as well, which can tend to come from oatmeal or bees, peas, lentils. And especially with the bees, peas, and lentils, those are also really good sources of protein. So sometimes adding those can kind of give you really good bang for your buck. Physical activity is important. Again, I know it can be a struggle for some. It can help to overcome treatment-related side effects, but sometimes, obviously, if you're so fatigued and you don't feel good and you're nauseous, it's hard to get the motivation to do it, right? So sometimes it's a vicious cycle, but it really can help improve pain, mental health, overall quality of life. And even reduce the risk of recurrence for some cancers. So overall, the optimal guidelines are to aim for 150 minutes of light to intense exercise throughout the week. And again, I say light to intense because this is really going to depend on the patient and what they were doing beforehand and what they feel capable of doing now. And they can be 10 minutes or more, and for some people, this might mean just walking around the house or up and down the stairs for 10 minutes at a time at a pace that feels good for you, or doing chair exercises is really going to depend on the person. And there is a program called Exercise for Cancer to Enhance Living Well, and it offers a free 12-week exercise classes that are designed specifically for individuals undergoing or recovering from cancer treatment. So I learned about that 6 months ago, and I just include that because, obviously you look into it and see if that could help you. Of course, some patients will have surgery as part of their treatment. It's done for many different reasons, and there are, of course, different types of surgery. But every time you're going through surgery, there's obviously a recovery period. So it is always going to affect your nutrient needs because our bodies need extra calories and protein to heal. So your dietitian or myself may give you specific suggestions depending on the type of surgery, but also leading up to your surgery. There might be a window, say of, 3 days, 5 days a week, where you're recommended to eat a very specific diet. But other than that, leading up, the weeks or a couple months leading up to your surgery, making sure you have good nutrition. So getting enough calories, getting enough protein, getting lots of vitamins and minerals and antioxidants can help ensure that you have the proper stores of those nutrients and help with faster recovery, lessen your chance of infection, less time spent in the hospital, and less chance of complications. So, there's lots of different nuances when it comes to surgery. So of course, it's important to listen to your surgeon and follow their specific instructions. And if you have any questions or kind of struggling with anything, to work with your dietitian as well. So dietary supplements, when I say, dietary supplements versus nutrition supplements, dietary supplements is more like herbs or really high doses of vitamins or minerals. And there isn't enough research really to support that taking antioxidants, herbs, or extra vitamins and minerals in large doses can help to treat cancer. Now, in certain cases, it might be harmless, such as, taking a certain amount of vitamin C, but too much is not a good thing, too much is not always a good thing either. So it's always important to, again, talk with your healthcare team, talk with your dietitian, talk with your pharmacist, because some of these supplements can also interfere with certain medications. So just make sure you talk with your healthcare team. Nutrition supplements include ready-made high protein and calorie drinks or powders that you can add to drinks. So most people don't know them, like Onshore or Boost or, Beta-protein powders. And I know they kind of get a bad reputation because, yes, of course, they are processed and things like that. But for some people who are just feeling so unwell that they can barely get out of bed or they can't stomach food, I mean, they can absolutely be useful in certain situations and help to make sure that patients can get in enough calories, enough protein, because malnutrition and cachexia can be really detrimental. So sometimes it's just about preventing those things and making sure you're getting enough fuel so that you can heal, recover, and get better. So there's, again, everybody going through this process or journey or treatment is going to be different in what type of symptoms that you have, whether it's nausea, vomiting, upset stomach, diarrhea, constipation, right? There's so many different things. So I'm going to go through a few different, symptoms that might present and ways that you can help manage these symptoms. But I'll go through pretty quickly. Again, just the interest of time. I want to get through the presentation. I want to be able to answer questions. And again, each and every person's situation is unique, right? Some people might experience diarrhea, some constipation, some neither of those, right? So some of this might not be as applicable, but it is in the presentation so that if you do want to copy afterwards, you can access the information. So again, some people, their appetite is affected. They have nausea. They might have dry mouth. All of these things can impact appetite and make it very difficult for patients to meet their nutrition needs, right? Or even just a lack of energy and fatigue and not having the energy to make large meals. So typically recommended that you eat small meals every 2 to 3 hours. Larger meals tend to, sit heavy in the stomach or cause GI issues. Drink higher calorie liquids such as juice and milk, ideally in between meals, because again, sometimes it can affect appetite if you're drinking it with a meal. For some people, that might not be the case. So if you have no issues and your appetite's good, then drinking with a meal is fine. This is more so for people whose appetite is affected. You can add, again, higher calorie things such as cheese to potatoes, vegetable soups, or pasta, beans, again, or lentils to salads, soups, casseroles, and rice dishes. Anytime that you can kind of add to what you're already doing and just increase the calories to kind of meals or foods that you already have. Nut butter on toast, oatmeal, fruit, or add it to a smoothie. Nuts and seeds are great. Again, some people can't tolerate certain beans or nuts or seeds, so it really depends on the person, but adding them to things can really help boost the calorie and nutrients, protein of what you're already eating. So adding nuts or seeds to oatmeal or yogurt or pudding or salads. Choosing higher fat products such as 2% milk and yogurt versus the low fat, melting margarine over potatoes, rice, pasta, and cooked veggies, again, just to increase the calories. Use avocado on anything that you can, really, if you like it. Using mayo. If you are losing weight, again, rigorous exercise is not ideal, but light activities such as walking or chair exercises can actually stimulate appetite and help with digestion. So again, there's a lot of benefits to that light activity, even if you're not really feeling that well. Again, nausea and vomiting can be a symptom depending on the person. So eating 6 to 8 smaller meals a day. Some of these overlap, which is kind of good because they can help with multiple symptoms. Sipping on fluids throughout the day, eating softer, blander foods instead of foods that are fatty, greasy, or spicy, eating dry foods such as crackers, toast, or dry cereal, excuse me, taking ginger extract. Of course, that should be approved by your doctor and pharmacist, because anything that you're going to take that's supplement wise could impact medications, but it can be something that can help. Sucking on hard candy such as peppermints or lemon drops if your mouth has a bad taste in it. Again, some people experience diarrhea, some constipation. So there's different ways that you can manage these nutrition wise. So for diarrhea, drinking plenty of clear fluids throughout the day, which is going to be especially important to help replenish some of the electrolytes that you're losing. What's also important is consuming foods that contain sodium and potassium, because that's also replenishing the electrolytes that you're losing, such as soups, sports drinks, crackers, pretzels, potatoes without skin, and ripe bananas. Avoid caffeine and alcohol. If it persists more than a day, if it persists more than a day, it's important to consult your healthcare practitioner. But some people, when they are experiencing diarrhea, they can become lactose intolerant, even though they can consume lactose just fine any other time. So you might want to limit if you are experiencing a diarrhea for more than a day. Consume foods that are high in pectin, such as applesauce and bananas. These can naturally help to thicken the stool. And avoid greasy, spicy, or very sweet foods. Again, Felicia, I won't go.
Felicia, yeah? I'm sorry to interrupt. Is that
That's
you
okay.
controlling the cursor?
Yes, I'm sorry.
No, I'm just always leery of someone hacking into these presentations. So I just wanted to make sure that it's you moving that cursor the way it's moving. Okay.
It is. And I think it was more so me trying to draw my own attention to the words and not realizing what I was doing. But yes, that is me.
Thank you.
Sorry about that.
No, that's quite all right. Thank you.
So again, I won't go through all of these. Eating higher fiber foods, again, can help form the stool. Limiting higher fiber foods, because they can help, the thing, I lost my train of thought. Sorry.
Sorry.
That's okay. That's not your fault. I totally understand wanting to make sure that there's nobody in here that shouldn't be.
Yeah.
Okay, so we're on diarrhea. So we want to limit higher fiber foods such as whole grains, fried beans, cabbage, broccoli, and Brussels sprouts. Again, we don't always want to limit higher fiber foods when we're in these situations where we want to reduce it. It's just for a short period of time until the diarrhea clears up. Lying down after a meal. Sometimes when we have diarrhea, it's because we're having a quick transit time. So lying down, but on an incline, can help slow down digestion in that transit time so that it's not coming out as quickly and urgently. Certain foods such as sugar, alcohol, sorbitol, mannitol, that can trigger diarrhea for some people. Certain supplements such as magnesium or vitamin C. So again, if you are experiencing diarrhea, talk with your dietitian or your healthcare provider to see if some of these might help you improve your symptoms. Constipation, again, some people may experience constipation. It could be because of medication. It could be IBS related. It could be diet related. Some people getting not enough fiber in the diet, not enough probiotics in the diet, not enough fluid can lead to constipation. So it could be a number of different things. So just trying to make sure you are getting enough higher fiber foods, drinking enough fluid, asking your doctor which medications might be contributing to constipation, and then maybe doing some of these other things. If you have to stay on that medication, doing some of these other lifestyle changes can help with forming the stool and moving it through so that you're not getting constipated. And being dehydrated, of course, is not good for anybody, but especially for cancer patients going through treatment. So it's important to take in small volumes of fluid frequently. Again, especially if you're experiencing nausea and vomiting, try to keep a water bottle with you at all times. I know some people are better than others at getting their fluid intake. I work with some people, they drink lots of fluid daily, and some people where it's really a struggle. So try setting an alarm, Post-it notes, whatever works to help kind of remind you, okay, I need to stop and take a break and have a drink. Some people do great when they habit stack. So that's basically take a habit that you're already used to doing, such as making coffee in the morning or while you're making a meal or snack, just to try have a half a glass of water. And it's something that's realistic and manageable. And then that then becomes a new habit. You can suck on ice chips or popsicles, especially if you have nausea, that can certainly help as well, but just really important to stay dehydrated. And I've kind of alluded to this throughout the whole presentation, but it really is important to have one-on-one nutritional guidelines, especially during cancer treatment, because there's so many different factors that can influence your nutrition needs before, during, and after treatment. So it's important to work with a dietitian who can perform a nutrition assessment based on your goals, your history, your current eating habits, where you're at with your cancer and with your treatment, and provide you specific nutrition recommendations and interventions and meal plans and ideas based on your unique needs. And of course, as I'm sure with most people, you would be having your healthcare team monitor your weight and nutrition status, but just, advocate, make sure that that is being monitored. And again, I am here for support. So if you need one-on-one support or have any questions, then please don't hesitate to reach out. Foodborne illness, which people often call food poisoning, is an illness that comes from the foods that we eat. And sometimes bacteria, viruses, or parasites attach to food. And then if they're kept, especially if they're kept in what we call the danger zone, so, not in the refrigerator, not at the proper temperatures, they can continue to grow and grow and grow until it becomes an amount that's going to cause an actual foodborne illness. Sometimes we can't see, taste, or smell when these foods grow. And usually illness happens between 1 to 3 days after eating the food, or sometimes even up to 20 minutes. Symptoms include vomiting, diarrhea, stomach pain, flu-like symptoms. Of course, it can happen to everyone, but for people who have a weakened immune system, such as from cancer or cancer treatment, are at higher risk of getting a foodborne illness. So it's really important to take extra precautions to minimize that risk. So again, these are just some suggestions to help reduce the risk of foodborne illness. So clean your hands and surfaces often. I know many people do, or most of us do, but just the more you can do it, the better. Make sure you're always washing cutting boards, dishes, utensils with hot soapy water, especially after you prepare a food item such as chicken, raw chicken. Make sure everything gets washed appropriately and avoid cross-contamination. Use a glass or plastic cutting board instead of a wooden one. They are easier to clean and less chance of bacteria leaching into the wood, which can happen. Use paper towels to clean up surfaces if you can. Bacteria, viruses, and parasites can tend to grow more on wet or dirty cloth towels and sponges. But if you do use them, which, obviously many people do that anyway and don't want to use or waste paper towel, just make sure you wash them often using, again, hot soapy water. And replace, if you use a sponge and you're washing it out after each use, replace that every 2 weeks. Clean the lids of canned goods before you open them. Sometimes, through travel or transportation, bacteria can get on the outside of the can as well. Wash raw fruits and vegetables well before eating. Put all raw meats, poultry, and seafood into individual bags, and make sure that you store these foods above produce you do not store them above produce and other foods that are not cooked before eating. Never put cooked food on a plate that previously held raw meat. So again, make sure that those plates and or cutting boards get washed extensively. Use a food thermometer to check the internal temperature of the products. And again, I'm not going to go through all of them, and it's not an exhaustive list. There's a lot more. So if you have any questions about food safety, feel free to reach out. Something that's really important that I talk to a lot of my clients about is a healthy relationship with food. There is a term called orthorexia nervosa, which is a proposed disorder characterized by an obsession with only consuming clean and pure food, which I see a lot of the time in cancer patients after their diagnosis. Again, they become very fearful, and it's completely understandable, right? Sometimes you question, what led to this, and was it something I did? And please try not to think that way, although I know it's easier said than done. when it comes to diet, I know there's a lot of messages out there that, promote clean eating or, especially in the past 5 to 10 years, even that term itself, clean eating has exploded. And of course, yes, as we know, a diet rich in fiber, fruits, vegetables, and low in processed foods and added sugars is of course good for our health. Completely restricting these foods is unnecessary and can even backfire, because a lot of the time these disordered eating patterns can lead to an eating disorder and issues with mental health, and can have a profound and negative effect on people's lives. And a lot of the time too, when people are so scared to include certain foods, they restrict their diet so much that it can result in digestion issues, malnutrition, deficiencies, hormone balances. So again, sometimes these can do a lot more harm than good. So I like my clients to focus on addition, not restriction. So have balanced meals, focus on getting more protein, making sure you're getting enough calories, especially if you're going through treatment and, recovering from surgery, all these things. It's preventing malnutrition, and especially in these scenarios becomes the most important thing versus, feeling like you have to eat a completely clean diet. And then please be careful of the social media content you consume. Misinformation sadly spreads faster than the truth, usually because it elicits fear and touches pain points. And this is why there's so many wellness influencers that have millions of followers, even though they're all saying conflicting things, right? If we listen to every single wellness influencer out there, all we'd have left to eat is air, because there's people now demonizing fruits and vegetables. There's people demonizing meat. There's people, everything. So if we listen to all of them, we would, we would not be in a good place. So just please remember that the dose makes the poison with a lot of these things. So I wanted to leave room for questions. So I have a couple of quick videos. So I probably won't show all 3, even though they're only about a minute or a minute and a half each. But even if you yourself aren't on social media, like I know, again, everybody's different. Social media can still shape a lot of people's views, either indirectly, right? They're through family members who are on social media, or, there's a lot of documentaries that kind of act similar to social media. So these documentaries can tend to cherry pick data that supports their claims, but it's confirmation bias. You can search a research study on almost anything and get a conflicting information. So a couple of these videos kind of summarize that pretty succinctly. And I just wanted to say for the videos, a lot of the time what it's showing at the beginning is the person that's sharing the misinformation. And then there's like an evidence-based professional that comes in and kind of debunks what they're sharing. So I just wanted to share a couple
things you don't know that are harming your health. Processed snacks. First things first, the length of this ingredient list is beyond alarming. Amongst this list, there are toxic acids, oils, fillers, artificial flavoring, and much more. And this could be why you're experiencing so many health issues. So here's a general rule of thumb. If you don't know how to pronounce an ingredient or even know what it is, chances are you should not be consuming it.
Okay, so this lady is saying that Doritos are the reason why you're experiencing so many health issues. I'm going to have to strongly disagree. Time for school. She made a pretty bold claim. So I want her to show me evidence that a single one of these ingredients causes or increases the risk of disease at the dosages found in a Doritos packet. The point is, she won't be able to. So attributing a packet of Doritos to the reason for your ill health is just beyond ridiculous. And for the 17th time, disease is not caused by a single food. Demonstrated in this study of over 100,000 participants, they found that for every 10% increase of ultra-processed foods in your diet, your risk of cardiovascular disease goes up by 12%. Further backed by this systematic review of 20 studies, showing that decreasing the proportion of ultra-processed foods decreases your risk of several diseases. So a more accurate recommendation would be to encourage the reduction of ultra-processed foods in the diet relative to whole or minimally processed foods. So it's the proportion of processed foods that are the problem, not the snacks themselves. Next, she says that the length of the ingredients list is too long, and if you can't pronounce it, chances are you shouldn't be eating it. And as a holistic, integrative health coach, she's clearly extremely qualified to talk on this subject. Extremely qualified. So let's test this theory. Okay, so here we have an ingredients list of a food. And first of all, this list is long, so let's see what's in it. Already it's a no, we got fructose, glucose, maltose, galactose. We know how bad sugars are. And the amount of preservatives, we've got octadecanoic acid, hexadecanoic acid. Wow, the number of E colors, E160A, E161B, E140, the list goes on. And I can't even pronounce this thing, dimethyl 4-hydroxy-3-furanone, 4-vinyl guaiacol. Okay, so whatever this food is, it's clearly very toxic. Oh, it's just a kiwi. Right. Well, I'll just let you guys think about this.
You've been told that all vegetables are good for you.
This is because
That is bullshit.
oh boy, here we go. Let's hear what he has to say.
I'm going to show you 5 vegetables that I strongly believe are hurting you.
So in the field of research, we have something called the levels of evidence hierarchy. Here is said hierarchy. It's really a systematic way we can assess the strength of research's applicability, which can help us make informed decisions about health guidelines and clinical practice guidelines. Many experts in the fields will objectively and comprehensively evaluate and assess research across all levels of this hierarchy before making intelligent decisions about clinical practice guidelines and health guidelines. Unfortunately, his argument starts off with "I strongly believe," which is important to keep in mind in light of the hierarchy.
This fills you with oxalates, dicarboxylic acids that cause kidney stones.
So the first supporting data we see here is a case report, as you can see on the screen, which falls right here on the hierarchy. I read that case report, so you don't have to. It was a report of a 65-year-old female with a history of gastric bypass surgery, type 2 diabetes, and prolonged antibiotic use. She went on an extremely restrictive 10-day juice cleanse and developed some kidney problems from it. She didn't have any other sources of energy, just the screen juice. Unfortunately, this is not sufficient data to scream at 2 million people that vegetables equal kidney stones, especially considering that not all of his followers are 65-year-old females with the exact same medical history and environment growing up.
Implicated in neurologic disease and animal models.
Alright, so animal studies, as seen right here, are at the bottom of the pyramid for a reason. The reason is, we aren't mice. Of course, animal models have done so much for our mechanistic understanding of many disease pathologies, but any scientist would be sadly mistaken if they thought they could make a blanket statement about humans with what they learned from their mice.
Kale, full of isothiocyanates, which will disrupt your thyroid by inhibiting the absorption of iodine. Kale is absolutely bullshit.
So I read this research review, so you don't have to, which discussed a number of different studies, most of them being animal models. And yeah, the conclusion of this...
So I just wanted to include that one. I apologize for the language, but because she talks about the hierarchy of evidence, and again, a lot of these, whether it's a documentary you see on TV or whether it's something you see on Facebook, TikTok, Instagram, wherever it is, a lot of the time when people are spreading misinformation, they'll cherry pick data to support their claim. And then that's where it sounds really compelling. It sounds like it might be true. But we know that we have to look at the overall evidence when we're informing our any type of health claim, but our nutrition claims as well. So I do want to show the last video just because it's cancer related, but it will only be about a minute and then we'll wrap up.
McDowell Children's Hospital in Austin, Texas. We're going to see what they serve in the cafeteria in a children's hospital. Western medicine doesn't really care what they feed patients. Pretty sure they don't care what they feed kids either, which is even more saddening. So let's go check it out. We'll see what's in here. Banana cake with 409 calories. Reese's peanut butter cups. I got flaming hot Cheetos, orange vanilla Coca-Cola. It's like every other hospital cafeteria in the United States, except this one is a children's hospital, which makes it even more striking. We should treat our children better. How will our physicians, our nurses ever set an example for our kids, for their families, when this type of garbage food is condoned, is served in the cafeteria here? It's crazy. We need to do better for our kids.
This video really pisses me off. When I was 25 years old, I was diagnosed with stage 4 cancer. It spread from my femur to both of my lungs. I was a gym rat. I was 215 pounds, ready to take on the world. After almost a dozen surgeries and multiple rounds of aggressive chemo, less than a year later, I was 145 pounds. Yes, cancer kills. We all know that. But you know what else kills? Malnutrition. And malnutrition affects a large majority of individuals with cancer. You physically and mentally cannot bring yourself to eat. And when you don't eat, you start wasting away. So yes, these hospitals have cakes and cookies and candy. These are high-calorie foods that are typically easier to stomach. And when you are wasting away from malnutrition, you eat whatever you can, whenever you can. Messages spread by creators like this are not only nonsense, but they are potentially life-threatening, and they absolutely should not be allowed. Platforms like this need to do a better job of moderating this type of message.
So again, I truly believe, again, after working with so many people, that social media and media in general, you might not be in social media, but there are other forms of media that impact and inform people's views and their beliefs around nutrition and health. So it's just so important to think critically when you're absorbing this type of information, and look for other sources and look at what sources the person is providing. And because there is a lot of misinformation out there when it comes to cancer as well. So I felt that that was really important to talk about, and to show some of, I really found over the past 5 years, there's more evidence-based professionals emerging that are debunking misinformation. So I really love that that's happening. And, you know, I follow a lot of those creators. So yeah, it's important to seek out creators that are evidence-based and kind of debunk those myths. Just some key messages quickly before we get to the Q&A, but focus on getting enough fuel and eat when you feel good. Try to set timers if you need to have small meals throughout the day. And when you are having a period where you do feel good, then try to consume more calorie dense foods that are higher in protein, higher in calories. Try not to get overwhelmed. Focus on making one small change at a time. Ensure your care team is monitoring your weight and nutrition status. Stay in touch with your registered dietitian, because again, your needs could change depending on where you're at in your journey. Do your best to practice food safety, and just try to include healthy sources of proteins, fiber-containing carbohydrates, healthy fats, vitamins, and minerals. Avoid significant weight loss. Again, I come from the perspective where, yeah, I work with patients who have cancer, but I've also worked with lots of people in the public where they want to lose weight, right? So there's kind of this disconnect, whereas now it's so important to try not to lose weight, especially when you're going through treatment, and focus on getting enough calories, protein, and nutrients in general to help support your immune system and help provide the energy you need to feel your best and to fight. So again, here is my contact info. I will try to answer as many questions as possible. I think some came up in the chat. But if I can't get through all the questions, or if you would like to reach out for one-on-one support, I apologize. I was going through things a little bit quickly because, you know, in the interest of time, and I wanted to leave room for questions. So yes, feel free to reach out at any point if you want one-on-one support.
That's great. Thank you so much. Felicia, would you like to stop sharing your screen, and we'll take the questions at this moment?
Absolutely.
Okay, here we go. Okay, so the first one is it true that grapes are full of sugar and bad for your health?
Absolutely not. I 100% no. Fruit is not bad for your health. Yes, fruit has natural sugars called fructose, but they are not bad for our health. I know, again, that's just some of the misinformation that's out there. Grapes have lots of benefits. All fruits have benefits. Grapes have sorbitol, which is a natural laxative. So I sometimes recommend them for people who are having constipation as well. Figs, grapes, prunes, things like that. So absolutely not.
All right. What are your thoughts on kombucha?
So kombucha obviously is a fermented drink that has probiotics. I shouldn't have said obviously, because some people might know what kombucha is, some people might not. So it has been shown that, you know, probiotics are really helpful for gut health, and many of us do not have enough what we might call healthy gut bacteria or probiotics. You know, as with anything, too much is not necessarily a good thing either. There is some evidence that, you know, particularly for cancer patients, we don't want to be eating too many fermented foods, but we absolutely do want some in the diet, because that's going to help replenish our gut bacteria and make sure that our gut is not in a state of dysbiosis, which just basically means that it's not balanced, which can happen after, you know, years of not getting enough probiotics in the diet, or not enough fiber, or taking harsh medications. So we absolutely want some in the diet. And kombucha is not the only source of probiotics. There's probiotics in dairy foods, in sauerkraut, kimchi. And so, yeah, important to get some in the diet, but as with anything, not too much.
All right. Is there omega-3 in white fish?
There is. So we say the highest amount, the fish, that has the highest amount of omega-3s is your fattier fish, such as salmon, mackerel, trout, tuna, and herring. So those would be the highest amounts, but any other fish that are less fatty still has omega-3s. It's just not in as high of amount as our fattier fish, such as salmon.
Okay. And I heard that cancer feeds on food. So the more you eat, the more you are feeding the cancer cells. And this has to do with, Felicia, I'm sure you know, starving, that period of time just before you're actively undergoing treatment.
Absolutely. And you know, I totally get where that is coming from, but your immune system needs fuel. So yes, there are of course periods of time where you want to be eating less and you listen to your surgeon or your dietitian, but for the most part, we need fuel, and especially people going through cancer treatment need more fuel than the average person. So we need more calories, we need more protein. So what's going to matter most is preventing malnutrition and preventing cachexia, or at least help to mitigate what cachexia can cause. So please don't be afraid of food. Don't be afraid of fuel, because all of the, you know, the vitamins and minerals and nutrients are going to help support your immune system, which is going to help fight the cancer. And of course, your cancer treatment is going to help fight the cancer as well.
And the last question, is Metamucil safe for a patient to consume?
Yes, so Metamucil is basically psyllium fiber. So it's a type of soluble fiber that comes from psyllium husk, and you can get just psyllium husk on its own, and it's going to act in the same or similar ways, but it's not as pleasurable or pleasant, I should say, to drink or to add to foods if you're just adding psyllium husk to things. So Metamucil can just be a little bit more realistic for somebody to kind of drink, and it's a little bit more flavorful, but it is the same thing as just adding psyllium husk, and it can be really helpful for not only getting enough fiber, which is important for gut health, but for it's kind of has a paradoxical effect in the research that it helps people both with diarrhea and constipation. So, you know, as long as, again, you clear it with your pharmacist, healthcare team, make sure that there are no interactions with your medications, it should be safe.
That's great. Thank you so much, Felicia. Are there any additional questions for Felicia?
There's a hand up there from Julie.
Parviz. Okay, so Parviz, you've been off mute for a while now. You're muted.
No, my question, hi Felicia. My question to you is that everybody knows sugar is no good for the cancer cell. They say cancer cells feed from the sugar. How about the natural sugars in the food? Of course, you answer, but is there a limit for that? Because organic honey that I eat as a breakfast with the butter, and then blueberries and all these berries, how do you think about them guys, about the sugars in those fruits? Because let's say I eat about half a bowl of small bowl of blueberries and blackberries every morning. So what do you think of that?
So the sugar that's found natural in fruit is not something that we have to limit. Yes, you know, we know cancer will feed off of sugar, but, you know, we can't starve ourselves. We can't just not eat calories, fuel, you know, natural sugars. So it's really important to kind of distinguish that fact. Yes, we want to limit added sugars, which anything such as table sugar or honey or maple syrup, any type of syrup, is what we consider added sugars. And it's recommended that we consume less than 24 grams of added sugar daily, which is about 6 teaspoons. So again, what matters most is what we're doing, you know, consistently over time. So you're getting those fruits and antioxidants and vitamins and minerals from your fruit. Those are going to help support your immune system. So it's important to have fruits in our diet, but we just want to limit the added sugars. And then on the other side of it too, like there are patients that are just going through treatment and they have absolutely no appetite. They are nauseous. And then there's certain foods such as you know, cookies or cakes in a short period of time, if that's all that somebody really can stomach, and if that's how they're going to get their calories, and no, do we want to do that for a long period of time? You know, absolutely not. But for some people, like in that video where he's a psychiatrist and he was going into the hospital and demonizing all the foods that were there for the patients. Well, for one, the patients get different food than what's available in the actual cafeteria. But for some patients, you know, for the average population, yes, we want to limit our added sugars. But what I'm just trying to say, it's important not to demonize them, because for some people who are really struggling to eat anything in general, sometimes they might have to reach for those foods with added sugar because that's all that they can tolerate.
So Felicia, truthfully, I have to share this with you. Because of the risk of cachexia onset when it comes to our metastatic patients, and the fact that some have difficulty eating and are quite debilitated when they do start treatment, they ask, Philomena, what is it that I can eat? What should I be eating? I'm having difficulty. And I do suggest always that they have this very thoughtful dialogue with their treating oncologist. I say, eat, just eat, because we want there to be maximum caloric intake so that they can endure these treatments and move on quite well. So I just say, eat whatever it is that your heart desires.
I love that. And honestly, that's where I go a lot of the time with it too. And that's why I say my approach is so unique, because yes, I try to, you know, take into account the guidelines but there are so many factors that influence what a person can and cannot eat, especially when they're going through treatment. And for some people, they can only stomach chicken nuggets and fries and cookies. And honestly, for the period of time we're going through treatment, less focus on clean eating. And I use that term loosely because I don't like the term clean eating, because that's why I use quotes, because again, going back to healthy relationship with food, it makes an assumption that there are foods that are unclean or that there's a moral value tied to what we eat. And it's always, you know, you want to balance the optimal recommendations, but what matters most is getting enough fuel, getting enough calories, getting enough, you know, protein for healing and recovery. And yeah, I love that. I absolutely echo what you said.
I had a patient who called me and said, Philomena, I had a Big Mac last night and I kept it down and I feel stupendous this morning.
Absolutely. And that's realistic. And that's honestly, you know, that's why I talked so much about people having fear around foods and fear around, but, you know, nutrition research is so complex, right? There are so many things out there that can increase your risk of cancer. Sitting increases your risk, right? There's so many different things. And research is not always correlation doesn't equal to causation. A lot of the time, it's all the different factors that we're doing. So if we're doing our best to increase our activity, increasing our, you know, the nutrients that we do get for the most of our lives, but if there's a period of time or 2 to 4 months where you're going through surgery or treatment and all you can stomach is, you know, the quote unquote ultra processed foods, then getting the nutrients in is ultimately, and preventing malnutrition ultimately becomes the most important thing.
For sure. Thank you so much, Felicia. I know we do have 2 additional questions, but we will forward them along to you so that you can reply to them. Patients would love to speak with you all day. I that much, but we are mindful of time and we would like to proceed to the next guest speaker. So thank you so much for spending your time with us today. You were just lovely and so very informative. So thank you, thank you, thank you.
Thank you so much for having me. It was my pleasure.
Oh,
take care, everybody.
And I see that Nicole McCormick is here, so I'm going to once again share my screen. Go on to the next one. Hello, Nicole. Welcome.
Hi, everyone. Thank you for having me here.
Just going to, here we go. I'd like to introduce you properly, Nicole. And I have provided you with sharing privileges so that you can then bring up your presentation. Okay?
Okay.
Nicole McCormick. Nicole is an adult gerontology nurse practitioner with 14 years of clinical experience in cardiology, nephrology, transplant medicine, and oncology. Before joining Natera, Nicole served as faculty and a clinician at the University of Colorado at UCL. Nicole is passionate about patient and family education and believes care is most successful when patients and their families are active members of their healthcare team. In her free time, she can be found teaching and practicing yoga and enjoying the Colorado outdoors. I am very pleased to introduce you to today's final and much anticipated expert speaker, who will be addressing a topic that is quite relevant and of great interest to both our earlier and advanced stage patient population: the access to ctDNA testing in Canada. Signatera is now available in Canada through LifeLabs, and Ms. Nicole McCormick will speak to the tool and its introduction in Canada. Won't you please join me in welcoming Ms. Nicole McCormick from Natera?
Thank you, everyone. Let me share my screen now. Okay, so I'm going to talk today about the utility of ctDNA in the management of metastatic colorectal cancer, but we'll also touch on just the general use of ctDNA in all types of cancer, as well as earlier stage colorectal cancer. And I believe we'll have questions at the end, but if you want to type them in as they come up, that would be great. Okay, oops. Let me go back here. Okay, just as a disclosure, as was mentioned, I am a Natera employee with salary and stock. And then here's what we're going to talk about today. So first we'll talk about, what is ctDNA and why is this something that we're interested in tracking in solid tumors, some of the different types of ctDNA testing, and then, why would we care about ctDNA and how do we use this in our clinical care when it comes to cancer management. Specifically focus on colorectal cancer and then looking at immunotherapy treatment response monitoring as well. So let's talk about ctDNA in general and, how do we manage, someone's cancer? What is their tumor burden? How are they responding to treatment? And so currently there's a few ways that doctors manage this. First is with imaging. So I'm sure many people are familiar with getting CT scans, PET scans, MRIs. And so this is really good. It gives us a picture of what's going on inside the body. However, cancer has to be of a certain size to show up on this imaging. Next, there are clinicopathologic characteristics. So this kind of tells us more details about the tumor and how likely it is to recur or spread. So some of these things include, other health conditions a person might have, if lymph nodes are infected with the cancer, and then what the tumor itself looks like when they look at it under the microscope. How aggressive are those cells? However, sometimes a tumor looks very risky, but it doesn't always correlate to how the patient does going forward. So they may not have any recurrence of cancer, even though their tumor looked very aggressive when it was removed. And then last, I think many people are familiar with these serum-based protein biomarkers. So this is blood tests that can be used as tumor markers. So things like a PSA in prostate cancer, CEA in colorectal cancer. And so these tests are useful in that they're very easy, right? So it's a blood test. It's pretty easy to obtain. However, they're not very sensitive at specifically identifying cancer tumor burden in the body. For example, CEA can be high for a number of other reasons aside from colorectal cancer. It can be related to other gastrointestinal kind of illnesses, liver disease, things like that. And so those are not very targeted specifically to measure tumor burden. And so one of the things that we're interested in identifying is how can we tell if a patient's cancer has been adequately treated, say with surgery or with chemotherapy and radiation, and how can we tell if the cancer is likely to come back? And so one thing that can be measured is something called molecular residual disease or minimal residual disease. And the abbreviation for this, or the acronym, is MRD. And so MRD is being able to detect cancer at the molecular or cellular level. So are there a few cells of cancer left versus a clump of cells that is large enough to show up on, say, a CT scan? And so MRD detection is widely used in blood malignancies, so things like lymphoma, leukemia. However, we've begun to be able to identify a way to detect if cancer is persisting, say, after a patient has undergone surgery for a solid tumor, as well as if it persists after they've had their chemotherapy, their radiation. And again, the goal is to detect this at very low levels before it shows up on imaging, before it's large enough to show up on, say, a CT scan. And so you can see from this chart, it kind of, the graph shows that, you know, when tumor levels or tumor burden, tumor load gets to a certain amount of volume, we'll be able to see that tumor on imaging. But we can also detect at very low levels with sensitive testing when there are just a few cells in a person's blood of their tumor. And so that allows us to see, answer a number of questions, which we'll discuss here shortly. And so let's talk a little bit more about circulating tumor DNA, or ctDNA, and why does this come in handy for assessing molecular residual disease. So just like all the cells in our body, cancer cells have their own DNA. It's specific to that tumor. Just like all the cells in our body, they have a limited lifespan. So our cells naturally die, they pop open, some DNA spills out, it floats around in our blood for a while, and then our body breaks it down and it goes away. And so same thing with the cancer cells. So over time, cancer is continuously growing. Those cells, though, do die, are replaced by new ones, but that circulating tumor DNA spills out and can be found traveling through the bloodstream. So this allows us to say, is there active cancer in a person's body? And the interesting thing about ctDNA is that it doesn't last very long in the blood. And so if we see that it is present on a blood draw, we know that the cancer is active at that time. The half-life, or the amount of time that circulating tumor DNA lasts in someone's blood, is about an hour or so. Within 24 hours, it would all be gone. So this is a very time-sensitive test that lets us tell if there is a tumor burden in a person's body at that time. Okay, so how can we check for ctDNA? There are a few different options. So first, there are some tumor-naive assays or blood tests. So in these types of tests, the person's tumor is not analyzed. What we have found is that certain types of cancer have certain genetic markers. And so they kind of will say, this is a panel, a static panel of genetic markers that we're going to be looking for in the person's blood. And so it then can say, do we see these genetic markers? Yes or no. And so we'll talk about the pros and cons of both types. But for this type, again, we're not actually analyzing the person's specific tumor. We're just saying, we know they have colorectal cancer. These are some signatures of colorectal cancer. Let's see if we can detect these in the bloodstream. The other option is a tumor-informed assay or blood test. And so in this type of test, the actual tumor tissue is analyzed, and what we're looking for is the fingerprint of that specific tumor. Identify test patterns that we'll check going forward to say, do we see this fingerprint in this person's blood at this time? And so this is very personalized, and as you can imagine, because it's personalized to the specific tumor, it has a high sensitivity in being able to detect if that tumor is present in the blood. The other benefit of this type of testing is that we can track the amount of ctDNA over time. So not only can we say, do we see the ctDNA in the person's blood with this blood draw, yes or no, but we can say how much is there. And then the next blood draw, we can say how much, is it more or less? So it gives a little more detailed information. And so just to compare the two, as far as on the top column here, we have the personalized tumor informed versus on the bottom here is the tumor naive panel based. So you can see the advantages of the personalized, and this is what you would expect. It's personalized specifically for your tumor. And so it's very sensitive and very specific in picking up if the tumor is present in the blood. It, again, as I mentioned, allows us to track the amount of ctDNA in someone's blood over time. And it's very reliable if we track this test over time. The limitation here is that it requires us to DNA sequence the tumor. And so that can take a few weeks. And so it can take a little longer for this first test result to come back. It also, again, requires tumor tissue. So we would need to make sure that there is enough tumor tissue available in order to develop the test. As for the panel-based tumor-naive MRD assessments, they do not require tumor tissue. So it's a little bit easier logistically. We don't have to get any tumor from the pathology lab. It doesn't require us to know anything specifically about that specific person's tumor. But because of that, there is a lower sensitivity and specificity. So meaning these results can sometimes show positive because of other just normal variations that might be found in someone's blood. And again, it doesn't allow us to say how much circulating tumor DNA is detected. It just says, do we see something? Yes or no. Another benefit though is it can be run a little bit more quickly initially because we're not needing to do that DNA sequencing of the tumor. And so let's talk specifically about Signatera. So Signatera is the tumor-informed approach that I mentioned. So it's personalized and tumor-informed approach, and it uses a sample of the person's tumor. And so what we do is we receive that piece of tumor tissue. We're able to, again, look for this fingerprint. So we look at the DNA of the tissue, say here are up to 16 kind of targets, or again, swirls of that fingerprint that we are going to be able to track going forward. We know that they're going to stay present over time, even as the tumor continues to perhaps evolve. And they'll be present even if this tumor responds to treatments, because they're not the mutations that are targeted by treatments. And so again, we develop this fingerprint. And then what we're able to do going forward is draw the blood and look for those 16 targets, yes or no, presence in the blood. And if they're present, then we're able to say how much is there. And so this is an example of what the Signatera test looks like. So again, in the top left-hand corner here, you see that binary positive or negative, but then our report gives you the historical results as well over time. And so when it's positive, it's usually a filled in circle. And when it's negative, it's this open circle. And down here, you can see that it's telling us how much tumor molecule is present in that specific sample. And these numbers alone don't necessarily mean anything. It's more comparing them to each other. So here we can see this person's level was 48 initially in January of 2021. And then over time it decreased and eventually went to 0. And so that's where this tumor-informed approach really comes in handy, and being able to say, let's track someone's response to their treatment. Is it working? Are they getting rid of this tumor burden? So let's talk a little bit more about why we would want to use ctDNA in caring for patients with cancer. And so there are kind of 3 main questions that ctDNA Signatera helps clinicians answer. The first is to say, am I at risk for my cancer coming back or spreading? And this is especially useful after someone's undergone surgery with the hopes of removing totally their cancer. So can we see, is there any tumor left, even though we thought we got it all on surgery? Is there still any of this molecular level tumor left? The second question is my cancer coming back? So if a patient has undergone surgery, they've completed chemotherapy, their scans look clear, now we're going to be tracking going forward for relapse or recurrence. ctDNA is a good way to help monitor for that. And then lastly, as I mentioned, monitoring treatment response. So you're on chemotherapy, undergoing radiation, perhaps on immunotherapy. Is this treatment working? Is the tumor shrinking and hopefully even going away? And so let's look at some of the data that we've accumulated to answer these questions using Signatera. So first, the question, would additional therapy benefit my patient? So on the left-hand side, this is bladder cancer, and this is patients who'd undergone surgery for bladder cancer. And then they were looking at treating them with atezolizumab, which is a type of immunotherapy afterwards. So this is kind of the post-surgery continued treatment. And what they found is that patients who had evidence of this molecular residual disease, so they had positive Signatera or positive ctDNA detected in their blood after surgery, did see a benefit. So this is down here, this lower level of receiving additional treatment after surgery. Whereas patients who did not have detectable ctDNA after surgery, there wasn't really a clear benefit in them receiving additional treatment. So this is a way to really say, okay, you will benefit, and on the other hand, maybe you won't, and so we can spare you the treatment side effects. Similarly, we found the same type of results in colorectal cancer. So these are patients, this specifically is stage 3 colorectal cancer, who had surgery. Surgery looked like it was successful, but then in saying, okay, what does the Signatera test show? So here, these bottom 2 lines are patients who had ctDNA or Signatera positive after surgery. And you can clearly see here that patients who then received chemotherapy had much better survival than those who did not. Whereas up here, the blue and the green are patients who did not have detectable ctDNA after their surgery. There was no real benefit from them receiving additional treatment. And so again, can we spare these patients the side effects of chemotherapy? So that's one way that Signatera can be useful to the treatment team. Next, the big question, is my cancer coming back? And so we've done testing with Signatera in colon, breast, lung, and bladder. And what we clearly see is that when ctDNA is detected, so positive, the blue in all of these charts versus the green is when patients have had surgery and there's no further ctDNA detected in their blood. Patients who continue to have ctDNA after surgery have unfortunately much lower relapse-free survival. And again, this picks up before imaging anywhere from 2.5 months in bladder to up to potentially 10 months in breast. And so again, this really alerts the team that something is going on here and perhaps additional treatments would be beneficial, or closer monitoring with imaging and other ways of following up for recurrence. And then lastly, the big question that many people have is this working? And so while someone is on treatment, they often wait several months while on treatment to look at the imaging again. And so you might go 3 months between CT scans and maybe potentially even 6 months between PET scans. How do you know in that in-between time, is this treatment working? So here on the left in colorectal cancer, we found that patients who were on their adjuvant chemotherapy, so again, they had surgery and then they went on to receive chemotherapy. If they were able to clear, so they initially had ctDNA detected after surgery, they started on their chemotherapy, and during chemotherapy, if they went to negative, so ctDNA was no longer detected, their disease-free survival was almost the same as patients who had no ctDNA right after surgery and then remained ctDNA negative throughout treatment. So this shows us that if you're able to clear your ctDNA while on treatment, it's working. You're going to have much improved outcomes going forward. And then on the right, this is looking at immunotherapy response monitoring. So this is in 25 different tumor types. These are patients with advanced cancers, metastatic disease, that were treated with immunotherapy. In this case, it was pembrolizumab. And again, what we found was that patients, this top blue line, who were able to clear their ctDNA during the time that they were on immunotherapy, had 100% overall survival. And this goes out to a little over 2 years. And so that's excellent results. So it really allows the treatment team to identify excellent responders to treatment versus patients here in this solid blue line whose ctDNA continued to rise while they were on that immunotherapy treatment, had unfortunately much worse overall survival. So it was really showing that the treatment was not effective, and being able to identify that early on could allow the treatment team to offer additional treatments, or perhaps a different treatment, or perhaps see if a clinical trial would be appropriate. And so it's a one way to say, again, is this treatment working? Okay, so let's talk specifically about colorectal cancer and using Signatera. So when Signatera was first developed, this was kind of the foundational study looking at, can we use ctDNA to tell us anything about colorectal cancer, the risk of recurrence specifically? And as many of you are probably aware, CEA is kind of the blood-based biomarker that's the standard of care in looking at colorectal cancer. And so the main question here is, how does Signatera compare to CEA in being able to detect cancer recurrence? And so you can see here, the majority of these patients were stage 2 and 3, and all of them were deemed to be surgical candidates. The teams thought that they would be able to fully remove their tumors with surgery. And what we found was that ctDNA in the blue as compared to CEA in the yellow was much more sensitive and specific in detecting relapse. And so sensitivity is saying, okay, how well are we able to identify someone with their cancer recurring? How well does this test pick that up? And so 88% of the time we were able to say, cancer's back, yes, Signatera found that. Only 69% of the time could CEA show that. And then specificity is more like, if the test is negative, how likely is it that, yes, that's true, the patient doesn't have recurrence? And 98% of the time that was accurate with ctDNA, Signatera, and only 64% of the time was that accurate CEA. So often patients may have a normal CEA, yet their cancer is recurring. And so as you can see here, ctDNA Signatera is a much more accurate test to detect relapse. That makes sense, right? We know it's designed specifically for that patient's tumor. It's personalized. So I think that makes sense, but that was kind of proof of concept for Signatera. And then what we found was that if a single test was positive, Signatera positive, 97% of those patients went on to relapse without further treatment. So that would be, they had their surgery alone, but one time they were ctDNA positive after surgery. If they did not get chemotherapy, 97% of them would eventually have their cancer return. And then the benefit of tracking that over time is then to say, okay, so let's treat these patients, and then being able to assess, are they responding to treatment or not? Alternatively, with a negative test, if we see that one time point after surgery was negative, we found that about 12% of those patients would still go on to relapse after surgery. However, if the patient remained Signatera negative through 2 years post-operative, the risk of relapse was down to 3%. So again, that offers a lot of reassurance that additional treatment is not necessary and that the patient is likely to do well going forward. So let's talk about a little bit more data in the colorectal space. So Japan is running a study called Circulate Japan, and this is actually a 3-armed study. So you can see here, this middle section is called the Galaxy study. And this looks at over 1,000 patients, and it's observational, meaning we check ctDNA, but it doesn't change how the patient is treated, and their medical team is not using that to make any types of decisions. We're just gonna say, let's draw this blood every 3 months, see, and then compare it to what happens going forward. There are these interventional arms, meaning where if a patient is ctDNA negative after surgery, then it will kind of determine their treatment course, as well as if they're ctDNA positive, again, what kind of treatment might be beneficial that's different than the standard of care. But right here, we're looking at this Galaxy study. And so this is patients with stage 1 through 4 colorectal cancer. But again, they're deemed to be surgical candidates. The teams think that they'll be able to fully remove all of the cancer with surgery. What they found here was that ctDNA was the biggest factor in determining the likelihood of relapse. And so often when patients have colorectal cancer, they're looking at like the tumor size, how deep it's infiltrated through the colon into the, say, the muscular level or beyond, if there's lymph nodes involved, to kind of assess the risk of relapse. But what we found here is that really ctDNA is really the only thing that makes that really tells us, will a patient recur or not? And so this is looking at 4 weeks after a patient has had surgery, and this graph is specifically looking at stage 2 and 3, that we can clearly see patients who are ctDNA negative in green versus ctDNA positive in blue have a much improved disease-free survival. And in fact, it's like a 10 times improved overall survival. Okay, so that's kind of what we would think. So then what if we go on to give chemotherapy? So in looking at patients who are ctDNA positive, Signatera positive at that 4-week post-op treatment, or time point, do they receive a benefit from adjuvant chemotherapy? And the answer here in green is clearly yes. And so we know that chemotherapy will work in these patients. It helps them have improved disease-free survival. Now, what about clearing? And this is kind of what I had showed with further data than what I showed initially. So again, here we see that if patients who are positive at the 4-week time frame then undergo adjuvant chemotherapy and are negative by 12 weeks postoperatively, their disease-free survival is quite excellent as compared to patients who were negative and then had turned positive while on treatment, or patients who were positive and remained positive or did not clear their ctDNA during treatment. And so again, it's a marker to say, is this treatment working? And then lastly, the question of, what about patients who are ctDNA negative 4 weeks after surgery? Do they need chemotherapy? Is there a benefit? And what we found here, you can see these lines pretty much overlap. The answer is no. So even if someone's tumor looks like it's high risk, this is again, high risk stage 2 or stage 3. So based on guidelines in the US, these patients would be recommended to receive chemotherapy. There's really not a benefit that we can see. And so can we spare these people the side effects that come along with chemotherapy, as well as the time of undergoing treatment, the financial burden of treatment, that sort of thing. And then lastly, looking specifically at metastatic colorectal cancer patients. So again, these are patients with metastatic colorectal cancer, but felt like to be able to be surgically removed. And so these patients had surgery, and then they tested for ctDNA, and then they went on their treatment, and then they had follow-up going forward. And this is 112 patients. And again, what we see is that if patients are negative after their surgery, so even though they had metastatic disease, it was deemed surgically resectable. If they're negative at that post-operative time point, they have much improved disease-free survival and overall survival based as compared to those who are still Signatera positive at that post-operative time point. And again, this is saying that when they did the surgery, everything looked clear. And then again, comparing to CEA. So you can see on the left here, this is looking at CEA was normal in this blue line versus CEA was considered positive or high abnormal. Here, there's really not much of a difference in disease-free survival between these two. Whereas with Signatera, there's a clear difference between patients who were ctDNA negative in blue versus ctDNA positive. And so again, Signatera is a much more sensitive test in detecting relapse going forward. Okay, so let's talk about a couple of patient cases to maybe make this a little more, understandable, because I know that was a lot of scientific data. So here is a 64-year-old patient who had left-sided colon cancer and had 3 months of treatment with Xelox. And this was in 2018. So in 2019, they were found to have an enlarging pulmonary nodule, so concern for metastatic disease to the lung. They attempted to biopsy this nodule, but it came back pretty much negative. Lung nodules can sometimes be difficult to biopsy. And then also, you're just getting a little bit of a needle piece of the tumor. And so you may get an area that's already kind of been dead, necrotic by the time you're able to biopsy it. And so it said, no, this is not cancer at that time. The patient really didn't want to do another biopsy, but there was concern this was growing. So Signatera was ordered to help kind of see what's going on at the molecular level. It came back positive for ctDNA. And so the patient then said, okay, yes, let's try another biopsy. And this time the biopsy came back consistent with metastatic colorectal cancer. The patient was able to undergo the metastastectomy, so the nodule was able to be removed. And then they were trying to decide, okay, should we give additional chemotherapy? However, this was in March of 2020, and we all know what happened in March of 2020. That's when COVID was starting. So the patient was very reluctant to undergo chemotherapy at that time, understandably so. And so Signatera was once again ordered to say, okay, let's see, did we get everything with that surgery that we just did to remove that nodule, that tumor in the lung? And in this case, it came back negative. And so that was reassuring. After discussion with the patient, their family, the medical team, they decided to let's hold off on additional treatment and just continue to monitor with ctDNA. And so this is where this test can be helpful. It's another piece of data that the treatment team and the patient and their family can use to make decisions. Okay, here is another case, a 35-year-old woman with stage 3 colon cancer who underwent surgery, and the CEA was still elevated at 4.8. She was treated with 3 months of adjuvant FOLFOX, and then the CT scan after completing adjuvant chemotherapy looked good, no evidence of disease, but her CEA was 9.6, so even higher. Another CT scan 3 months later, or 6 months later, shows no evidence of disease. However, the CEA is still elevated 6.7 and continues to rise. So the patient's saying, like, what's going on here? Why is my CEA rising? But you're telling me my imaging looks fine. And so they went ahead and ordered Signatera, and it was negative twice, even though, as you can see here, CEA was considered positive at that time. And because we know that Signatera, again, is personalized, tumor informed, and much more accurate than CEA, this was reassuring to the team. And so her CEA was elevated for other reasons. And as we mentioned, CEA can be confounded by other types of gastrointestinal illnesses that could be going on. Okay, and then lastly, I'd like to talk about using ctDNA in immunotherapy monitoring. Because this is something, immunotherapy is a treatment that is used in more advanced cancers. And so one of the things that you can do is, if you have a CT scan with metastatic disease, your patient is deemed a candidate for immunotherapy, you can start to track ctDNA to see, is this going up or down? And again, Signatera is different in that it allows you to really get that amount of ctDNA detected in the blood. Sometimes when patients are on immunotherapy, the way immunotherapy works is it harnesses the patient's own immune system to try to fight the cancer. And as we know, when our immune system starts to attack something, it often causes inflammation, swelling. And so it can make the tumor look like it's actually growing. And so ctDNA can help clarify that. Is the tumor bigger on imaging because it's growing, or is it because of the immunotherapy actually working and causing that inflammation and cell death? And then if you see that it's not working because ctDNA continues to rise while the patient's on treatment, then you can start to say, okay, are there other treatment options? And then if a patient clears ctDNA, as we saw from that data, that is a really good prognostic signal. And so perhaps after a couple of years on treatment, you can say, now we can take a treatment holiday and see how you do off of this therapy. And so one of the main studies that showed that Signatera is beneficial through immunotherapy monitoring was this INSPIRE trial. And so I touched on this earlier, but this looked at patients with 94 patients with advanced solid tumors in a variety of types of cancer. You can see there on the bottom left. And these patients had, again, advanced metastatic disease, and they were treated with single agent pembrolizumab, which is a type of immunotherapy. And what we found is that Signatera was positive for 98% of these patients before they started treatment. And that's excellent. You would expect that to be hopefully 100%, since we know they all have active metastatic disease. But there are some types of cancers that might not shed quite as well as others. And so 98% of these patients did have detectable Signatera before they started treatment. And then we went on to track every 6 weeks, how was Signatera doing in response to their time on treatment. And again, I mentioned this earlier, but we saw that the patients who cleared their ctDNA, so went from positive to negative during the course of treatment, they had 100% overall survival, again, going out to 25.5 months. So that's excellent for patients with advanced disease. Patients whose ctDNA dropped while on treatment but didn't fully clear had some response, had an average, say, if you will, overall survival. But patients whose ctDNA continued to rise while on treatment, unfortunately, had a much worse overall survival. And so, again, you can really identify who's responding. Great, let's stick with it. Who is maybe responding a little but not clearing? Okay, is there anything else perhaps we could add? And then patients who are not responding, again, is there another treatment available? Is there something else we can add? Is there maybe a clinical trial that would be beneficial for them? And just to give you an idea of, how the medical team can use Signatera in conjunction with imaging when monitoring response to immunotherapy. So the patient on the left here is a patient with malignant melanoma. And so what we saw here is they started on treatment and their Signatera immediately cleared, became 0, negative, and stayed negative. Whereas imaging showed a slow decline in the size of the tumor over time. And so way we see response, even though imaging is taking a while to catch up. On the right here, we see someone with squamous cell carcinoma of the head and neck. And here, Signatera dropped a bit initially, but then by the second test, cleared and remained clear. So they were able to clear evidence of disease in blood. Oops. But initially showed a largening of the lesion, the tumor on imaging. So it was growing, even though Signatera was showing a decrease in tumor burden. And it took quite some time for this to actually show that on imaging that the tumor had cleared. So again, helpful for the team to say, okay, this treatment is working, even not look like it by CT scan, let's stick with it. talk about a couple more cases here. So this one is a 55-year-old female with a right-sided colon cancer treated with neoadjuvant, so before surgery, FOLFOX, and then underwent surgery. When they looked at the tumor surgery, they saw it looked like it had not responded very well to the neoadjuvant chemotherapy, so they underwent 6 more cycles post-surgical or adjuvant FOLFOX. And then soon after, the patient had a recurrence in their abdominal wall, which was able to be resected with clear margins. At the time of recurrence, Signatera was ordered and it showed positive, so it correlated with the fact that there was an actual recurrence. And then, you know, so we kind of see here, this is the initial surgery, and then here's the relapse. So Signatera, this is CEA, and then this is the ctDNA Signatera. So you can see here, CEA was elevated, Signatera was positive, they underwent surgery. And then after surgery, again, with clear margins, ctDNA continued to go up. So that was evidence that there was still molecular residual disease. And so given that, the patient was started on immunotherapy. And as you can see here, quickly cleared their ctDNA, indicating a good response to treatment. And these are just the imaging. And then again, metastatic colorectal cancer patient treated with FOLFOX and some additional treatments, and then started on immunotherapy with pembrolizumab. The patient experienced progressive disease, which also matched with a rise in ctDNA. So that's this bottom left. And CT scan showed recurrence. So, you know, they were on this immunotherapy. ctDNA continued to rise, and then they identified a recurrence. And so something needed to be switched. So the patient was switched to a different immunotherapy regimen, and then ctDNA dropped and a complete response was seen on imaging. It looked like it popped back up here, but eventually cleared again. We have another patient, similar metastatic colorectal cancer, treated with pembrolizumab. The ctDNA never fully cleared, and the imaging showed a progression. And so this patient was switched to a different treatment regimen. At first, you know, ctDNA was still kind of rising, but then it quickly dropped and eventually cleared. And so the patient was able to continue on immunotherapy and continue to experience ctDNA clearance. So those are my cases. Again, I think this was mentioned in the beginning, but Life Labs is the partner with Natera in Canada, and Signatera is available in Canada through Life Labs. So the website is there. There's also an email address and a phone number if you have questions about ordering.
Awesome. Thank you so much.
Yeah, and then we can see if there's questions.
Yes, absolutely. If you would kindly stop sharing, we'll take questions from the audience.
Oops.
Okay. Okay, ladies and gentlemen, we are happy to entertain questions at this moment. Has Signatera been studied in relation to rectal cancer specifically? And if so, have the results been similar?
Yes, Signatera has been studied in rectal cancer specifically, especially in the kind of total neoadjuvant treatment approach, trying to say, you know, is Signatera a good way to assess if a patient has responded to their total neoadjuvant treatment and then potentially avoid surgery? And we are finding that that correlates quite well. So it's a really good way to kind of provide reassurance if imaging looks great when a patient's completed their total neoadjuvant treatment and Signatera is negative, teams feel much more comfortable with holding off on surgery at that point.
Excellent. Can't see anything else here in the chat box.
Galomina, I've raised it's Suzanne. I thought it might be helpful to use myself as a case study because I have gone through this process with Life Labs and Signatera. So if that's helpful for people, I'll give a tiny bit of background that might help. So I was diagnosed with stage 4 colon cancer last summer, and it was believed to be resectable. So I had my colon resected in November, my liver resected in December. And so we decided, along with my care team, to go through the Signatera route to get testing to see whether or not it would make sense for me to go back and do more chemotherapy. So I did get that all arranged through Life Labs, actually at the end of December. So I snuck in before the official launch in January. Unfortunately, before my results came back, I had my CT scan, and I actually had developed a Krukenberg tumor, so on my right ovary. So not surprisingly, my ctDNA results came back positive because I had a massive tumor. So I went in and had that taken out. And so I'm back on chemotherapy, but have just done my follow-up testing. And we're looking at that both to see whether or not, okay, now that the ovaries and all of that's gone, is the cancer gone? But also I have a couple of nodules in my lungs that are just non-specific, that no one sort of knows what they are. And my CEA levels are currently at 0.9. So we're looking to see whether or not the ctDNA is going to show that actually that is a higher sort of risk of those being more metastases. And so I'm just waiting on those results now. So happy to answer questions if people have questions about that, but that's what I've done.
Thank you for sharing. Yeah.
Yeah, we actually have quite a few patients who have accessed it, who have accessed the tool, metastatic patients for whom it has been a reliable and an excellent tool at picking up residual disease that has then eventually correlated quite well with radiographic imaging. And they've gone on to access surgical resection for those tumors. So it's been wonderful. I know that Rob is not here today, but otherwise Rob would be able to speak to it as well. Thank you, Suzanne, for sharing. That's wonderful. Thank you.
Yeah, thank you.
Actually, we do have some additional questions. What about appendiceal cancer or other peritoneal metastases? I'm assuming she's referring to.
Yeah, so Signatera, can be used in any solid tumor. Appendiceal, we have some data on, appendiceal cancer is not quite as common as colorectal, so it's smaller numbers, but yes. As far as peritoneal cancers, there can be challenges depending on how much blood flow it's getting, how slow growing or fast growing. So the main thing with ctDNA is that different cancers have different biologies. And so some are growing very quickly. And so they're constantly new cells are forming and the old cells are dying, shedding that ctDNA. There's some other cancers like say prostate cancer that are slower growing, or thyroid cancer, that don't shed a whole lot of ctDNA. And so Signatera might not be quite as good at picking that up when the tumor burden is very small. And so we can detect peritoneal metastases, but GI cancers, because they are normally faster growing, have a good blood flow supply. In general, GI cancers, Signatera is excellent at picking up ctDNA.
Thank you. I was treated for a stage 3 right-sided colorectal cancer, and now CEA has been stable for 1.5 years. If I wanted to go through Signatera testing, what is needed? And that ties in with the next question, which is, does the patient pay for it or OHIP? So perhaps it's either you, Nicole, or
Dennis
Dobrovolsky, who's the product manager of oncology at Life Labs, has joined us today. So Dennis, please, if you'd like to speak to that.
Yeah, certainly. Thanks, Philomena. Thanks, Nicole. So in order to receive Signatera testing through Life Labs, you can go online to lifelabsgenetics.com/Signatera, and you'll be able to learn information about the test as well as how to order. Currently, at this current time, it is not covered by OHIP, but we are working with the ministry and various government regulators to gain coverage, and we expect that to happen somewhere in the next 1 to 3 years. So we're working on it, but for now it is paid for out of pocket by the patients. If you live in Ontario or British Columbia, then you can purchase the test directly online through that link. Or if you live outside those provinces, you can call the phone number listed. It's 184-GENE-HELP or 1-844-363-4357, or email ask.genetics@lifelabs.com, and they'll guide you through the process. So just want to note that, before buying the test, you want to make sure you talk to your physician, your oncologist, to make sure that they're okay with it, and as they will have to sign off on the requisition form. So basically, once you buy it, you'll be emailed automatically the requisition form, which you can take to your doctor. They will sign it, and then if you're in Ontario or British Columbia, you can come directly to one of the Life Labs locations, the patient service centers, to get your blood drawn. And then, yeah, that's the process there.
So, ladies and gentlemen, I think you know how passionately we feel, unapologetically, overly passionate we feel about this tool. We're going to be highlighting it at our June Biomarkers Conference, first and foremost, across multiple tumor types. And so seeing that we are hosting a number of clinicians at this conference, it's a perfect opportunity to be doing so. We are featuring it as a permanent fixture in our monthly clinical research updates. We are actually also highlighting it across our various social media handles for the next however many years. And so we're also going to be featuring it as an additional article and highlight through patient education sessions such as this one for the next 2 years. And we will participate. Parviz, if you can kindly mute, thank you. And we will continue, and we will participate in an HTA, patient evidence submissions, when the opportunity presents itself, so that we can inform those expert deliberative processes. So we won't stop. We eventually want to see this tool covered so that you'll all be able to access it. So I just thought I'd stick that in. So moving right along, how often should we be accessing the test Signatera? I had stage 2 CRC low grade, ctDNA positive, did FOLFOX for 6 months. My CEA is less than 4, but my oncologist says positive or negative does not mean anything. What do you think? So back at you, Nicole.
Well, I think that your oncologist knows your situation in much more detail than I do. I think that, we've clearly seen in numerous studies in numerous types of cancer that if someone has detectable ctDNA, that is evidence that there is some type of cancer remaining in their body. Now, will that go on to grow at an excessive or speedy rate? Not necessarily. One of the benefits of tracking ctDNA over time is to see, is it going up quickly, or is it holding steady at very low levels? That would be more reassuring that the tumor is not aggressively growing. As far as the frequency, I know that right now it is patient pay, and so that can be, expensive. In the US, we're seeing that if we're monitoring treatment response, often, so if a patient's on treatment and we're trying to see, are you responding to treatment, their providers are often ordering ctDNA every 4 to 6 weeks. If it is for recurrence monitoring, they often check it as frequently as they would say check CEA. So maybe that's every 3 months in the first couple of years, and then maybe every 6 months as someone gets farther out from their diagnosis and completing their initial treatments. Oftentimes providers might use it. So if they're only going to check imaging, say every 6 months, then at the 3-month mark, they'll check ctDNA. And if it was positive, then that prompts them to get imaging more quickly. So, it is very up to you and your treatment team as far as the frequency, but that's how we're seeing a lot of providers use it here in the States.
So Nicole, sorry, just to clarify, so in the metastatic setting, while patients are actively undergoing treatment, how often would ctDNA be checked?
For immunotherapy, say treatment monitoring, we're seeing it about every 4 to 6 weeks. Again, to say, is the ctDNA going down while you're on treatment? Then let's stick with it. Are you going up? Then maybe we need something different. This might not be enough.
That's perfect. All right. So this might be a little challenging right now based on the current setting, seeing that
exactly
out of pocket pay. So one of the questions that I do have is there some type of compassionate program that will be made available to patients who are eager to access this test? And I can assure you that everyone who has joined today is very eager to access this test because they want to be able to make an informed decision moving forward in respect of their treatment. And they do believe, that perhaps ctDNA can allow them to do that. So I guess it's to you, Dennis.
All right. Yeah. Well, we're definitely, looking at various options to make the test affordable to patients. And, that's certainly something that we're considering. And, we'll definitely let you know as soon as that becomes available. At the moment, I'm not aware of such a program, but certainly, we're doing our best to make it affordable and working with, our various partners, Natera in the US, in order to make that available.
That's great. That's very promising and hopeful. And they just want to be able to access it. That's all. And whatever it is that can help facilitate that would be very much appreciated. Very much. Thank you. Let's see. Are there any additional questions, ladies and gentlemen? Are you sure?
Okay. Hi. Here, I just want to get the quick cost on that test here in Ontario, I guess.
Yep. Please go ahead.
Did you hear that?
No.
The cost on a per test basis.
Okay. Yeah. So it's the cost.
Sure. I'm happy to answer that. Yeah. So currently the initial test, which is a one-time initial test to build your assay, your tumor informed assay, costs $4,500, and then every subsequent sample will be $2,000 Canadian.
All right, thank you.
So Dennis, can you just quickly summarize why it's so expensive? I mean, Nicole was great. She went through it in her presentation, but can you just quickly summarize why it's so expensive initially, seeing that there's a set, please?
Yeah, sure. Yeah, the reason is that, there's a very, sensitive and unique way that the test actually is built using whole exome sequencing. And it's able to take your tumor tissue and analyze it and compare it to your blood and really get a unique fingerprint for your cancer, such that you could detect like very tiny amounts of any tumor DNA in the bloodstream in the subsequent tests, which are used for monitoring. And so that initial process really requires a lot of, a lot of technological processes, like not only on the biology side, but also on the computer side, doing machine learning AI algorithms to really create that unique test for you. So that's really where the cost comes from. Hopefully we will be able to get the cost down, in the future. We just launched it, but we do expect that test price to go down as we gain coverage from regulators, not only public insurance, but also some private insurance programs, Sun Life, CanuLife, Manulife, those kinds of things. And certainly hope to get the price down and make the test more accessible for patients in the near future.
Okay, so it's an actual physical sample first, plus a blood draw, and then every subsequent testing will involve just a blood draw, essentially. Correct, Dennis?
Yeah, that's right. Yep.
Okay. All right. Any other questions? Okay. All right. Nicole, thank you so much for spending your precious Sunday with us. We are so, so grateful to you, truly.
Thank you all. I really appreciate the opportunity to speak with you all.
Thank you. All right, ladies and gentlemen, I know it's been a long session. We've been at it since 12:45. I wish you an absolutely outstanding rest of your Sunday, your weekend. We will be sending you along an evaluation form for you to complete because we are always looking to improve our patient education sessions. One thing that I will tell you is we will have a part 2 to this session where we will be inviting additional experts to speak on the management of the disease because we couldn't possibly fit all of our experts in one day. We would be here till, I'd say about 9 p.m. and I don't think you would have appreciated that. So stay tuned. We'll be in touch. We will be sending along a recording of this session so that you'll have an opportunity to sort of play it back. And we will also send along the copies of the presentations that were delivered today. The clinical research updates, the treatment and clinical research updates for the month of March will be sent along next week for your perusal, and they will be posted on our website. And one little bit of information that I do wish to share with you is we will be launching our new bilingual website within the next month or so, so stay tuned for that. If there aren't any additional questions or comments, I'd like to end this session by wishing you an absolutely wonderful rest of Colorectal Cancer Awareness Month. We are celebrating each and every one of you, and I wish you well. Take good care, my friends.